Good morning and welcome. Good morning and welcome. I am Kishore Visvanathan. I am so pleased to stand up here for yet another year and look out at this room full of excited people. This is just tremendous. I'm Kishore Visvanathan. I work as a urologist in Saskatoon, and I'm pleased to be one of the co-chairs of this year's Urology Symposium. And I would like to welcome all of you on behalf of our sponsors and the organizing committee. And I would like to thank all of you for attending, because without you here and without your energy, we'd have no reason to put on this conference. I would also like to recognize some of our sponsors, and I'll mention them by name in a moment. But I also want to thank, and I know you'll agree with this because I see some of you, many of you enjoying breakfast. I want to thank the staff at the Downtown Delta Marriott for organizing this room and putting on a great breakfast for us. So thank you to the staff. I see, looking out on the audience and also from walking around the room this morning, many guests who've attended this conference previously and many who have attended for several years. But also, I'm sure there will be some new attendees today. And welcome back to some of you and welcome to the rest. 11 years ago, we hosted the first Urology Symposium, and it was held on the day after the grand opening of the Leslie and Irene Dubé Urology Center of Health at St. Paul's Hospital. And I'm pleased to say that the Urology Center of Health is still running full bore and a great success. And I'm glad to say that this conference is as well. That symposium and every one since, including this one, has been funded by community, by you, your friends, your neighbors, who recognize the need for ongoing education about prostate cancer and gave generously to St. Paul's Hospital Foundation. The thing I love about this conference is exactly what I'm seeing right now. I'm seeing a community of people who are brought together by maybe a single need: prostate cancer diagnosis, prostate cancer treatment, prostate cancer survival. And this is such a great way to let men and their families know you're not alone. Look at all the other people who are thinking about some of the same things you are, going through some of the same things you are. And so making connections today will be really important. Also, we will be recording today's event and posting it to YouTube, so others who are not able to join us in person today can benefit from the information. If you registered for this symposium on Eventbrite, the link will be emailed to you, and please feel free to share it with friends, neighbors, someone else who you think might benefit from this information. To ensure that we have good quality in our video, please join me in taking out your phone that you think you silenced, but oh, we didn't. Okay, it is now. Please silence your phone out of consideration for everyone else in the room. And if you need to leave the room to use the washrooms, which are located in the foyer, if you need to leave the room, if you could try to leave the room as quietly as possible, because the microphones will pick up the audience as well as the speakers. This Urology Symposium is made available each year at no cost, as a no-cost public event. And this is thanks to the expertise and the leadership of those at the Les and Irene Dubé Urology Center of Health, and the generosity of our supporters through donations and sponsorship of St. Paul's Hospital Foundation. And I would like to thank specifically our presenting sponsor, Motorcycle Ride for Dad, who have been with us virtually every year, are a tremendous supporter in the community and support this event. They are a presenting sponsor, and they're at the back, and they've got their booth. You have to visit them at the break, and I really appreciate them. Thank you. We also appreciate our community advocate sponsor, the Saskatoon Prostate Cancer Support Group. Many men in this room may have taken advantage of the services that they have to offer. And if you haven't, then there's another great connection for you. And also this year, we're very grateful for support from Saskatoon AV, who have not only provided all the technical support to make this morning's conference a success, but also have offered us financial support. I want to recognize, if I can, this year's Volunteer Symposium Organizing Committee. And for the committee members, if you would stand or wave a hand when I introduce you, I really want to recognize the work that you've done. Nicole Baba, where is Nicole? Yeah, I think many of you know and appreciate Nicole, who's a nurse navigator at the Urology Center of Health, St. Paul's Hospital. Vince Stroikens. Vince is not here today, but he has been an important part of organizing this meeting. Vince is the ride captain with Motorcycle Ride for Dad. Dr. Kate Johnson, I think we decided, is not here today. Dr. Johnson is a radiation oncologist at the Saskatoon Cancer Center and is about to welcome her second child, so she's got a good reason for not being here today. Janelle Barch. Janelle is here. Janelle is the nurse manager at the Urology Center of Health and Ambulatory Care Services for the Saskatchewan Health Authority and signs all the checks to get this meeting done. So very important. I really want to recognize Sandhya Padmanabh. Sandhya Padmanabh is the Director of Philanthropy and Representative for St. Paul's Hospital Foundation, and has really opened up some avenues to get support for this conference. Dr. Mark Henbid. You are going to meet Mark a little later in our panel discussion. Dr. Henbid's training is in family medicine, and his specific interest is in men's health. And over the last year or so, he has been working really closely as an associate with Saskatoon Urology Associates to expand access and expertise to urology men's health diagnosis and care in Saskatoon and northern Saskatchewan. And many of you will know Murray Hill. Where is Murray? Murray's over in the corner. Murray is a patient advocate and is chair of the Saskatoon Prostate Cancer Support Group and is the Urology Symposium co-chair. And Murray has really reinvigorated the Saskatoon Cancer Support Group and made it really an important resource for men in Saskatoon and northern Saskatchewan. Oh, I'm on this list too. I'm Kishore Visvanathan, and I'm a urologist in Saskatoon. Thank you. And I'm a clinical professor of surgery at the University of Saskatchewan, and it's a pleasure to co-chair this great event. So thank you so much to all of this team for volunteering your time all year to organize this event. We also have a new event coordinator this year, and I want to recognize Anne-Marie Say. Anne-Marie is probably at the front desk. Okay. So when you see Anne-Marie at the front desk, you know what? I wonder if we could just get her to pop her head around the corner, because she's working away. Great. Thanks. Anne-Marie joined us as the event organizer. Anne-Marie is the principal of Wow Factor Events, and true to her business name, really wowed us and has done a tremendous job of ensuring that we have a really amazing event this year. So thank you to everybody. I also want to thank our exhibitors. Many of the repeat visitors here know that we have exhibitors who bring some of their services of interest to men and their families around prostate cancer. And so as I've already indicated, our presenting sponsor, Motorcycle Ride for Dad, has a booth. Please visit them. I also know that you'll recognize Brenda Yuzdepski. Brenda, please. So great to have you back. Brenda is a pharmacist at the Medical Arts Pharmacy downtown on Spadina and has really been an advocate for providing services and important medications and treatments for men who are recovering from and surviving prostate cancer. I also want to recognize, and you're going to meet her later when she gets you up and moving, Shannon. There's Shannon at the back from First Step Program, who's going to get us moving a little later. And I also had the chance to meet Bear from Osborne Erecade Canada. Bear, he's hiding behind a pillar, but he's back there. And so in our break, please take the opportunity to visit our sponsors. Also, Brenda and I believe Shannon, give me a thumbs up if I'm right about the draw. You have a draw? You do. So Brenda and Shannon have a little draw. You can enter your name, and they have a little fun prize for you that we'll announce at the next break. All right. It is now my pleasure to get on with the business of the morning. And I want to introduce our first guest, Mr. Brent McFadden, who's the co-chair of Motorcycle Ride for Dad, who we are thrilled to have with us in person. And he's going to bring greetings as our presenting sponsor. Motorcycle Ride for Dad has been sponsoring the symposium since 2015, and we really would not be here today without their ongoing support. Established in 2009, the Saskatoon Motorcycle Ride for Dad has raised over $1.7 million for the fight against prostate cancer. This is a tremendous amount of money. It is a tremendous amount of money, but it pales in comparison to the awareness that they spread every year, reminding men to get themselves checked for prostate cancer. This event, Motorcycle Ride for Dad, happens every June right after Father's Day, and you can find out more about it on their website, ridefordad.ca. And Brent is also going to make an exciting announcement in a few minutes. Brent, would you join me?
Well, good morning, everybody. Thanks for allowing us to be a part of this event over the years. It's something that's really exciting and it's really important to us. So, for those of you who may not know the backstory to Motorcycle Ride for Dad and its origin, it goes all the way back to 2000. And there was two gentlemen that were going to meet one morning and have coffee by the name of Charlie Pester and Gary Jans. So, Charlie shows up to have coffee with Gary, and he's late, and he seems a little bit distraught. And Gary goes, "Buddy, what's wrong?" And he said, "You know, I just came from the doctor, and he told me I have prostate cancer, and it's too late. There's nothing they can do for me." And that was something that really, really stuck with Gary. And he made it his mission, and he decided that that's unacceptable. And it was up to him, and he said, "There's something that can be done about this, and I'm going to do it." So that was the origin of Ride for Dad Canada in 2000. So here we are almost 24 years later, and nationally, Ride for Dad Canada has raised over $40 million to fund the fight. So we're certainly very proud to be part of that organization. We're one of 20 chapters that operates across the country. And as Kishore mentioned, we've done okay since 2009 in our ability to raise funds. And this year, 2024, will be our 15th anniversary ride, and we will cross the $2 million mark in funds raised. So stay tuned, watch for that. We've got a lot of exciting things to do and a lot of exciting events coming up and around town. So that's on the horizon for us. So this year, we're really pleased to have BMW Motorrad Canada come on board as a national sponsor. So BMW really stepped up for us all across the country. And one of the banners you'll see here actually speaks about a brand new 2023 motorcycle, which they have donated to us as the prize. So for every fundraiser who generates $200, they get an entry to win this bike. So the bike draw will happen in the next few weeks. And I can't even tell you how excited we'd be if somebody from Saskatoon or Saskatchewan won that bike. It would be simply amazing. So, you know, without those kind of sponsors and corporate partners, we couldn't do what we do. So we really make sure we shout out our corporate partners. We make sure that we give them all the exposure that they can, because they really help us produce what I would say is the best motorcycle event in the province that happens every year. So without further ado, I'm going to ask Sandia if she would like to come up here, and we might just have a little treasure. Okay, you ready? Yeah. All right. There it is. So, we're really excited about this, and this is an event that's near and dear to our heart. So as long as we are able to continue to support it, and as long as you guys are willing to have us show up, we'll be here, and we'll be here for you, because it's important for us. So I will let it go at that and turn it back over to Kishore, and enjoy the day.
At each of our symposia, we have intentionally started the meeting with a story from a local individual living with prostate cancer. And we do this to ground ourselves in the reason that we're here, which is providing support and hope. And so this year, it's my pleasure to welcome and invite to the stage Mr. Don Warkentin, who's going to share some of his insights and experience with you. Don?
Thank you, Kishore, and thank you, Anne-Marie, for the work that you've put into this event. Good morning, and welcome to Prostate Palooza. I put together a list of the top 3 ways to know that you are a cancer survivor. I hope most of you can relate to this. Number 1, your alarm clock goes off at 6 a.m. and you're glad to hear it. Number 2, you're back in the family rotation to take out the garbage. And number 3, when you no longer have an urge to choke the person who says, all you need to beat cancer is a good attitude. All right, I've got some slides here. Whoops, let's go back. I'd like to open by dedicating this brief talk to my dear friend Bob Clark, who lost his battle with prostate cancer on October 4th. Bob discovered he had cancer about 9 months before my diagnosis and provided me with much encouragement and support right up to the end. When Bob learned that the end of his life was approaching, I thanked him for all the support he gave me. His final words to me were, "Be an inspiration to someone who could use a bit of encouragement." I hope to provide some encouragement today. Murray asked me to talk a bit about my personal experience with high-dose rate brachytherapy. Now, for those of you who might not be familiar with HDR brachytherapy, it's like prostate cancer's worst nightmare. We're talking about high doses of radiation delivered right through hollow needles directly to the source. It's like telling cancer cells, you're not welcome here, please pack your bags and leave. It's so effective that even the cancer cells are thinking of starting a support group. When my doctor saw my PSA levels rise from 7.5 to 8.4, he ordered a biopsy. The biopsy came with a site of infection that didn't respond to the Cipro antibiotic that everyone takes prior to that procedure. By the time the emergency room doctor at City Hospital switched me over to another antibiotic, my prostate had nearly doubled in size. My prostate was the elephant in the room. The biopsy revealed a Gleason score of 7, early stage, intermediate risk. So I had options, which regrettably not everyone does. I was only 59 years old at the time, so radical prostatectomy didn't appeal to me, so I started exploring alternatives with our fine nurse navigators Karen and Nicole put me in touch with Murray at the Prostate Cancer Support Group, who then introduced me to a few men who had the low dose rate brachytherapy treatment. I'm so grateful to the guys who were willing to share their story with me. Their experiences were generally quite positive, but there was one major drawback to seed therapy. I was going to be radioactive for 3 months. Yes, I was about to become the superhero radioactive man. At that time, we were making plans to have our 2 granddaughters, ages 1 and 2.5, spend the summer with us, which fell right into the same timeline when I'd be the most radioactive. The thought of not being able to snuggle with these 2 cuties was too much to bear. But I had to look at the big picture. I wanted to be around long enough to see them grow up, so keeping my distance for 3 months would be a small price to pay. I met with Dr. Moore at the Saskatoon Cancer Center, and she ordered some tests. When my results came back, she told me that my prostate was still too large, so Edmonton wouldn't accept me into the LDR brachytherapy treatment program. She then told me about the benefits of high dose rate brachytherapy, which we'll hear more about today with Dr. Leong. With similar long-term results to radical prostatectomy and LDR brachytherapy and 0 radiation glow, it seemed too good to be true. The one negative point was that I'd have to travel to Regina and stay overnight. Sorry, Regina, no offense. Instead of the tagline, "The city that rhymes with fun," I'd like to offer an alternate marketing suggestion to Regina: the city of overnight medical miracles. My treatment began with 2 doses of androgen deprivation therapy. Last January, my wife and I had an assessment meeting with Dr. Leong in Regina. Dr. Leong encouraged us to take our time and ask as many questions as we needed. He never rushed us at all. As a testament to his skill, he listened to my heart and asked if I was aware of a heart murmur. I wasn't, so he referred me to a cardiologist in Saskatoon for follow-up, who cleared me for the procedure. Dr. Leong not only has a knack for treating prostates, but also could moonlight as a cardiologist. The date of June 20th was set for my brachytherapy, so I drove to Regina for a few days ahead of for the screening process. There, I had a rude awakening. Several months earlier, I was diagnosed with sleep apnea, but I, like many others, decided that the nightly CPAP hose acrobatics weren't for me. Since I wasn't using the CPAP machine, the staff at the screening center told me that I was no longer a suitable candidate for general anesthetic unless they could find an observation bed in Pasqua Hospital. Fortunately, they were able to find a bed before I left that day. What a relief. Turns out that my snoring skills weren't enough to keep me out of the medical spotlight, but at least I got a hospital bed instead of wrestling with a CPAP machine that night. On June 19, my wife and I traveled to Regina so we could be at the Pasqua Hospital for 6:30 the following morning. The next day, the anesthesiologist introduced himself and described how I was to be put under general anesthetic. For the procedure, he then asked if I knew that Dr. Leong wasn't going to be there. No. I didn't know that. No worries, he said. Dr. Amjad is here and he'll take good care of you. I didn't learn until several months later that Dr. Leong had moved to Calgary. I guess my prostate journey comes with surprise guest appearances. I was wheeled into a lead-lined bunker and thought, darn, I left my radiation dosimeter in the glove box. Dr. Amjad introduced himself to me before the anesthesiologist knocked me out. The next thing I recall is laying in a hospital bed in the observation ward with my wife waiting for me. I felt no pain, so I assumed that some painkillers were in my IV bag. I was shocked to learn that they had not given me any medication, nor did I need any, other than some slight nausea from the anesthetic I had no discomfort. That night was uneventful outside the usual hospital noises, and they discharged me around noon the following day. Who knew I had such a tough prostate? HDR brachytherapy was followed up by 23 radiation treatments with Dr. Moore in Saskatoon. My wife took the lion's share of caring for our granddaughters and took them out of the house for my daily naps. Bless her soul. She wanted to be here today, but she's on Vancouver Island with our grandkids while I'm here with you. Even superheroes need a vacation. The bottom line is that my testosterone and PSA levels have since returned to normal, for which I am truly grateful. The HDR brachytherapy was the least problematic of all my treatments, and I would encourage anyone who is fortunate enough to have that option to give it serious consideration. My gratitude goes to the pathway nurses, Karen and Nicole, Dr. Moore, Dr. Leong, Dr. Amjad, and the staff at the Alan Blair Cancer Center and the Saskatoon Cancer Center. I'm eternally indebted to the many friends and family who supported me and for the many snuggles I enjoyed with Elizabeth and Charlotte this summer. The biggest thanks goes to my wife, Kathy, who has been a constant support along the way. And to cancer, well, you may have tried to mess with me, but you clearly underestimated the power of love, snuggles, and a good medical team. Finally, thanks to all of you for listening, and I hope that my experience has offered you some encouragement and hope. If you have any questions, please feel free to pull me aside later or ask Murray for my contact info. I promise I won't charge a consultation fee. I'm just here to share my journey, have a few laughs, and maybe even throw in some free medical advice. Thank you.
Thanks, Don, for sharing that story. We know that it's not always easy to share those personal experiences, but always powerful, especially when you told us about your friend Bob Clark. Gave us both sides of the story, so thank you for that. As we're going along this morning, I'm realizing that there's some other people I forgot to thank, and I think I'm going to ask her to stand up. Karen, would you stand up? We've already said thank you to Nicole. Karen Moore is, many of you will know, is one of the nurse navigators along with Nicole Baba, who we've already met this morning. And Karen and Nicole support so many men and their families, and also continue on a Saturday morning in getting you registered and getting you into this conference. So thank you to both of you for that. And now it is really a treat to get into the presentation part of our morning. And I want to introduce our first keynote speaker. For those of you who have attended several of these seminars, you may think that talking about medical genetics is quite a departure for us. And if you think that, you're absolutely right. This is the first time we've considered the role that genetics plays in prostate cancer. But we are really pleased to have our guest speaker educate us about that. From a urologist point of view, this is particularly interesting to me, and I'm looking forward to this presentation because the role of genetics and genetic testing in prostate cancer and the way that is going to open up new opportunities for treatment for men is still emerging in urology. So if it's new for you, I have to admit that for urologists, it's also kind of new. So I'm looking forward to this presentation. I think you're going to find it illuminating, and it's going to expand some of your ideas about prostate cancer. So it is a pleasure to welcome to Saskatoon Justin Lorentz. Justin is a graduate of McGill's genetic counseling program and is a certified genetic counselor. He currently practices at the Sunnybrook Odette Cancer Center in Toronto, where he's the lead of the Male Oncology Research and Education Program, a registry for men with hereditary cancer. He also practices at MedCan, a private healthcare facility in Toronto. Justin is also affiliated with the University of Toronto as an instructor. His academic interest is in hereditary prostate cancer. Justin's talk is entitled Prostate Cancer Genetics, and it is a pleasure to welcome Justin to the podium.
Thank you, Kishore, for that. I have been known to stray away from the microphone, and so if that happens and I'm not clear or loud enough, please someone let me know. I'll be looking over here in general. It's a pleasure to be here. It's an honor to be here, and I'm really excited to be able to talk about this, newer aspect of medicine and how it's infiltrating into different parts of care, and particularly in the prostate cancer world. I was lucky enough to work with a physician, Dr. Danny Vesprini at Sunnybrook. He's a radiation oncologist who has a strong interest in genetics. And as we were working together, a lot of changes happened that I'm excited to talk with you about. So I have here, I'm a genetic counselor. I want to talk a little bit about what even a genetic counselor is. I want to do some orientation on things that we're very well aware of, cancer, but things that we might not be as well aware of. And that is, I wonder if I can get this. No, that's fine. That we might not be as well aware of, genetics. That might bring us back to, really, really early on. And even then, our understanding of genetics even 20 years ago is very different than it is now. I want to talk about genetic testing. I want to talk about how cancer, prostate cancer and genetics interplay. And then I want to talk about the impacts of knowing your genetic test results on prostate cancer, and whether it can predict things like aggressiveness, what treatment options that we could kind of entertain now that we know more about the genetics of prostate cancer. And then I want to talk a little bit about how we can access genetic testing. There's been a lot of work, particularly in this world, particularly in Saskatchewan. It's a lot to cover in 40 minutes, but I think I can do it. So let me start off with what a genetic counselor is. We celebrated Genetic Counseling Awareness Day. It used to be Awareness Week last week. And so a lot of my colleagues at the Canadian Association of Genetic Counselors created these visual tools to kind of explain what our job is. Because we're a few but mighty group of healthcare providers. So our job is to identify people who are at elevated risk for genetic conditions. Our job is to explain what a genetic test is, how that can impact an individual, really how that can impact a family as well if you find out that there is something genetic, because we share genes with our family members. We order genetic tests, we interpret the results of genetic tests, we explain those results back in a way that's hopefully easier to understand, and we facilitate referrals to where people need to go, depending upon their results. Or if the result's negative, we try to explain what that means for the individual. We serve as educators, resource people, and the counseling part is, understanding that when learning about some kind of a genetic predisposition can be a challenging thing. So we're trained on how to talk about this in a way, and also provide some support if we have to disclose difficult information. One of the main staples of a genetic counselor is to take this thing called a family tree. It's also known as a pedigree, but that makes people think about dog food. So we tend to say family tree. And essentially what we do is we have a graphical way of representing a family. Families are very dynamic, and it can be a really, sometimes challenging process, but it becomes an art project for us, where we are identifying the circles as females, squares as males. We can go one generation to the next, and in my world of cancer, what we're interested in finding out is what individuals have cancer in the family, and this is a nice way for us to kind of represent and see that. And so people who are shaded in are people who have cancer. And this is kind of our a staple thing that a genetic counselor will do when they interact and talk with individuals. So let me pivot to the next important thing that genetic counselors do. We talk about what genes are. And so genes essentially are pieces, long strands of DNA. They have instructions. They tell our body how to grow. They tell our body how to function. And we have thousands and thousands of genes. We have about 20,000 genes that make people people. Most of our genes are working just fine. And sometimes there can be mistakes or mutations that are present in those genes. We call them mutations because people are aware of what that means. The scientists call them something different. They call them pathogenic variants, super jargony. But I love people to know about this jargony word because it's the word that gets thrown around on medical records, and I love people to understand what the medical records mean. And so the word pathogenic variant means that there's a genetic change or a mutation in one of your genes. And I'll show you what a genetic test result looks like, super jargony. But I also like people to keep their genetic test results on site so that they can pass them along to family members, because I think this is a very important family piece of information to have. So genes are inherited. We get one copy of our genes from the egg, the other copy of the genes from the sperm. Sperm fertilizes egg, boom, we have 2 copies of a gene. And so everybody has 2 copies of all 20,000 genes. It's not exactly true, but for the purposes of this discussion, that's true. So what I have here is a woman and a man, and this woman has 2 working copies of her gene. Let's say it's a gene that's related to prostate cancer. And this man has 1 working copy, and the other copy has a mutation or a pathogenic variant in it. Now, if they go on to have kids, that woman will pass on either 1 copy or the other. It's a 50-50 over which gene copy is present in her egg that will then get fertilized by the sperm. But it doesn't matter which copy, because both of her copies of that gene are working just fine. The man, however, has a mistake or a mutation or a pathogenic variant in 1 copy of his gene. And so when he goes on to pass his sperm along, 50% of his sperm will have the mutation, 50% of his sperm will not. There's a 50-50 chance this gene mutation gets passed on to the next generation. This is a fundamental concept when it comes to hereditary cancer or the genetic aspects of cancer. Most cancer conditions that are on our radar today follow this mode of inheritance, where if someone has the mutation, there's a 50% chance it gets passed on. This is a super important concept, and I know in the question and answer discussion, we're going to come back to this. So, germline is another technical jargony word that we use. And so the word germline really refers to, we call them sex cells, eggs and sperm. These are germ cells. Other words that have germination. Sometimes you'll see wheat germ. So these are just the cells that make organisms. They're the sex cells. And so they're the sperm and the eggs. I refer to this because this is an important term when it comes to the type of testing that we do. So we'll think about Michael Phelps here as a really good swimmer, and our way to kind of connect him in some really loopy way to the word germline. Okay, so let's talk about cancer. So what cancer is, every single cancer is incredibly genetic. What happens in cancer is a normal cell that's perfectly healthy accumulates genetic mutations over time. And it can accumulate these mutations just by the cell dividing. And when if you photocopy 1,000 pieces of paper, maybe that 1,000th piece is not going to be as perfect as the first piece. And so as cells are dividing as we age, there could be mistakes that happen or mutations in genes. Exposures, UV exposure, geothermal radiation exposure, who knows what environmental exposures could also increase risk for mutations. And as certain cells accumulate the mutations in genes that protect us from cancer, well, maybe that one cell that accumulates the right mutations goes down this slope of becoming cancerous. And it evades the immune system, and then it starts being selfish. It starts dividing uncontrollably, accumulating more mutations. And it suddenly looks nothing like its neighboring cell that it was next to. It's completely taken on an identity of its own. It's become a cancer that's taking up resources in that part of the body. Sometimes it spreads to other parts of the body, it takes up resources there as well. This is a cascade of genetic events that happen. And so whenever you look at a cancer tumor, you will see in different parts of the tumor all these different genetic mutations because it's an evolving own little entity. So all cancers are genetic. So how do we test for these genetic mutations? Well, here's the interesting thing. When if someone has a gene mutation that comes in from the germline, from the sex cells that they inherited either from the sperm or the egg, I can test any part of their body to see if there's a genetic mutation in it. I can use a saliva sample, I could use a blood sample, I could use a skin biopsy, doesn't matter. any part of that person's cells will give me the information about whether or not there's a gene mutation inherited from mom or from dad. That's the most common type of testing, and that's either done through a saliva test or a blood test because it's usually just easy ways for us to do it. If someone does a germline genetic test, there's a chance that we're going to find a genetic mutation, but it's typically low. About 5 to 10% chance we find a gene mutation that they've inherited. 90% of people who get this type of genetic testing do not find a genetic mutation that's causing a problem. The other type of testing that we're doing now, that we've started doing in 2021, particularly in Saskatchewan, is tissue testing. And this is when we take a piece of the prostate tumor and we test it to look at the different mutations there. Now, you're always going to find mutations whenever you test tissue. They're full of mutations. But what the scientists are interested in, and really the scientists now being your physicians who are caring for you, they're interested to see if there's specific mutations that they can use to treat you differently. And so whenever we refer to genetic testing, we think of, are you getting germline testing to look at the genes you inherited, or are you doing tissue testing to see what mutations are present in your cancer tissue? Very important distinguishing factor. And I'll talk a little bit more about this, but both of these tests are happening to people in Saskatoon, in all of Saskatchewan, with certain types of prostate cancers. When we do a genetic test result, we can get different types of interpretations. So mutations are called variants in this case, and here at the end you see the pathogenic variant. We learned about that word, also a mutation. There's likely pathogenic. Most mutations are actually what we call benign or likely benign, non-problematic. And what that means is that when we do a genetic test, we read through a gene like we read through a book, we're looking for spelling mistakes or mutations. We find hundreds of them. That's fine. That's part of normal human variation. It's why people have blue eyes and brown eyes. These are all genetic mutations, but they're just not problematic. They just account for us being different. Our job is to identify, of any mutations that are present in someone's DNA, are they pathogenic? And if they are, that's a hereditary risk factor for cancer. And that's what I want to focus my presentation on. People who have these likely pathogenic or pathogenic variants. These are people who are rare. These are families that are rare. And our job is to identify these rare families and treat them differently based on this genetic finding. So if someone goes on to do a genetic test, this is from a hospital based in Toronto where I'm from. And this person here was found to have a BRCA2 gene mutation. I'll talk a little bit more about that. And then the word pathogenic is there for the clinical significance. Now we're all experts on what this word is. And there's another jargony word there called heterozygous. This is hard to see. It was difficult to screen this in. But these are examples of documents that are really important medical documents for people to hang on to. Your genetic test result should be something that's cherished and distributed with family despite the result. When it comes to these genetic mutations, I said that they're rare. 5 to 10% of people have a genetic mutation. It says 10 to 15. Prostate cancer, it's actually lower, 5 to 10. But lots of prostate cancer is still genetic, even if someone tests negative for one of these genetic mutations. And the reason how that makes sense is because all we can talk about are the known genes. There's a whole bunch of genes that are increasing risk for prostate cancer that we have no idea about. And so even if someone has a family history of prostate cancer, has prostate cancer themselves, has a negative genetic test result, it doesn't mean that there's not something genetic going on in the family. It just means that we can't identify any of the known genes. We're limited based on what we know in 2022 or 2023 now, soon to be 2024. The important thing about this slide is that most prostate cancer is sporadic. Most prostate cancer happens by chance, by the very natural process of accumulating mutations over time. That is how the majority of prostate cancers happen. So most prostate cancers are not due to some genetic factor. Most of them just happen by chance. There are 3 groups of people who are at elevated risk for prostate cancer. First group of people are men who have a family history of prostate cancer. And there's this one paper that did a really nice job of reviewing all these family histories. It's an old paper because this way of doing research had its time and place. And what it says is there's this word here called acronym FDR. That stands for first degree relative. That's a brother or a father, A second-degree relative is an uncle or a cousin or a grandparent. And the other acronym here is RR. That's relative risk. That means what is the risk compared to or relative to the general population. General population risk, 11 to 12%. Someone who has a brother with prostate cancer, they're 2.8 times higher. So that puts them up to about 30% lifetime risk for getting prostate cancer, any man who has a brother. Any man who has a father, his lifetime risk for prostate cancer is doubled compared to the general population. It's twofold higher than the general population. So family history is a big predictor. And any man who has a family history should be talking to their doctor about prostate screening. So first risk group. Second risk group for prostate cancer, individuals of West African, Caribbean ancestry. And we have no idea why. And that's where the research component of all this stuff is very important, because we still need to figure out what the genetic variants are. Now, West Africa, Caribbean, that's very specific. What connects these two areas together? The slave trade. And so we know that there's a specific pocket of individuals who had a genetic risk, and those individuals were enslaved and moved to other parts of the world, and we see that genetic risk still there. So there's something going on that's connecting these two populations that had the same origin, despite the fact that they live in different environments and spaces in the world. And so we're interested in learning more about that. Here's a heat map of prostate cancer incidence. And what I have here is the warmer the color, so red, means the higher rate of prostate cancer that's reported. The cooler the color, the blue, shows the lower rates of prostate cancer. We see North America, Scandinavian countries, Europe, Australia, some parts of South America, high rates of prostate cancer. This is mortality. These are individuals who pass away because of prostate cancer. And the map looks very different. Very few people in North America compared to West Africa are passing away from prostate cancer. We see people in South America and the Caribbean, high rates of mortality. And there's a graph that shows the discrepancy, where individuals of the Caribbean, the mortality rates are here. Individuals of Scandinavian ancestry, mortality rates are here. And we also know the Caribbean does not do as good of a job, or at least not at that time, in actually reporting how many people died because of prostate cancer. So we expect the numbers to be even higher. So we're interested in genetic factors that could come into play. A lot of men of West African Caribbean ancestry we do genetic testing on. We find nothing based on the known genes. There's something else going on. So we look at something called heritability. And I'm not going to go into detail on this, but essentially what we do is this interesting research where we take twins, identical twins that are genetically clones, they're genetically the same genetics, two individuals, and we take fraternal twins, which are brothers, genetically diverse. And we say, okay, when these men hit age 70, how many men get prostate cancer? And what we've realized in the world of prostate cancer is that a lot of the identical twins get prostate cancer at the same ages compared to the fraternal twins. We see quite variability. And it makes us think, it's probably because these two are genetic clones, and there's lots of genetic factors that are increasing risk that we just don't know about yet. Prostate cancer is one of those genes or one of those conditions where we see a high rate of genetic linkage, but we just don't know what those genes are at this point in time. At this point in time, we're stuck in something called monogenic, one gene that's connected to a risk. Whereas prostate cancer is probably polygenic, multiple genes that slightly increase risk in ways that are too complex for us to understand at this time. But our medical knowledge is here. So this is all that we can report on at this time. What this means is there's lots of work to do. In 10 years from now, this is going to be a very different discussion. But the field grows really quickly, and so I think even from 2 years from now, it's going to be a very different discussion. Okay, so that's my orientation to genetics in this space. What I want to do now is talk a little bit about prostate cancer specifically, and what we know about the genes that are connected to prostate cancer. This is a slide that I stole based on this really important paper that came out in 2016. And what they did is they took a bunch of men who had metastatic prostate cancer. This is prostate cancer that has spread to other parts of the body. And they did genetic testing based on the known genes. And they said, how many people have a gene mutation? And they found that 11 to 12% of men, 11.8%, 12% of men had a genetic mutation that was theoretically connected to their prostate cancer. In the world of genetics, that's a huge number. Nowadays, if someone has a 5% chance, we're interested in doing genetic testing. Well, here's a group of individuals with 12% chance, big number, changed our entire world. And the gene that we see most is this gene called BRCA2, and I'll talk a little bit more about that gene. This paper changed the whole face of how we approach, of how we will then in the future, which is now, approach prostate cancer care. But the world changes very quickly when it comes to this. Some studies, age really, really nicely. Other studies, there's controversial evidence that maybe suggests that it's not as true. This is one where we looked at, a study was done looking at individuals who have a very specific type of prostate cancer, and we thought that was connected to a genetic risk. And then a second paper came out by a very well-known author, Dr. Elena Castro, and she said, you know what, that's maybe not the case. Maybe that specific type of prostate cancer isn't as severely connected to a germline genetic mutation. Maybe it's more of the tissue gene mutations that we see in this cohort. Anyway, that to say, the world can change very, very quickly on this. And so this is my plug to say, keep genetics in your rotation, because we're probably going to have lots of new things to say in a couple of years based on changes and new papers that come up. So let's talk about the genes connected to prostate cancer. Genes are given acronyms and numbers. You get used to them if you work in them on a regular basis, but I recognize here that this looks like computer programming code for these, and so I'll do my best to explain some of the origins behind these words. So HOXB13 is a gene that was recently identified, and it's the only gene that's just connected to prostate cancer. In individuals who have it, the only thing that we think about is prostate cancer. If women have a mutation in this gene, no elevated risk, because they do not have prostates. Only men will present with prostate cancer if they have these HOXB13 genes, and it greatly increases the risk for prostate cancer. Gene 1 on our radar. The other genes, these are one of the probably more important genes, the BRCA genes. They're also called BRCA, and there's two of them, BRCA1 and BRCA2. Angelina Jolie made these genes important and famous, and because of her op-ed that was done in the New York Times, there was something called the Angelina Jolie effect, where more referrals came in, doubled the referral rate all across the country, and it stayed that way and just started increasing. So she did her op-ed changed people's lives. There's another person who's less famous, but his daughter's super famous. So Matthew Knowles, he got male breast cancer, was found to have a BRCA2 gene mutation, and is now getting prostate screening because that gene is connected to prostate cancer. Luckily, Beyonce and Solange don't have the gene mutation. Mary Claire King is the woman who is strongly connected to and was the main reason for the identification of these genes, BRCA1 and BRCA2. But these genes, they cause something called hereditary breast ovarian cancer syndrome. No mention of prostate cancer at all. And so the person who worked in Dr. Mary Claire King's lab said, hey, there's a big discrepancy here. A big chunk of people who are getting testing are women, even though 50% of people who have this gene mutation are also men. And maybe it's because it's branded as hereditary breast and ovarian cancer syndrome. Let's maybe call it King syndrome, after Mary Claire King. Anyways, it didn't fly, but a little bit of a story behind that BRCA2 gene. BRCA1 and BRCA2, this is a messy slide. What I want to show here is that they're not just connected with prostate, they're connected with breast cancer, ovarian cancer, pancreatic cancer, male breast cancer. So if somebody has this gene mutation and they have prostate cancer, immediately I think about their prostate cancer and their risk. Then I think about their sisters, I think about their brothers, I think about their daughters, I think about their sons, and what this gene could have in terms of implications for other family members, because we know risks are high. Other set of genes that we look at are genes that are connected to a condition called Lynch syndrome by Dr. Lynch, who identified this condition. Lynch syndrome connected to colon cancer, stomach cancer, pancreatic cancer, urinary tract cancer, and as an afterthought, also prostate cancer. So if we identify these genes in people, I suddenly start thinking, oh, well, you need to get a colonoscopy now. And I worry about your sisters or daughters' risks for uterine and ovarian cancer and colon cancer. And so it's quite dynamic. If someone has one of these gene mutations, it doesn't just mean that they're at elevated risk for one thing. They could be at elevated risk for a bunch of things, and so could other family members. And sometimes when we do this, a person may say, oh yeah, well that's true. My dad did have colon cancer, and my aunt did have uterine cancer, and then the whole story comes full circle, and it makes sense. The other genes that are, this is just showing the dynamic rates of cancer for each site and the different genes that cause Lynch syndrome. There's another gene that's well known to be associated with prostate cancer. It's called ATM, just like the ATM machine. And another gene, not CHEK1, but CHEK2, that's connected to prostate cancer. New guidelines just came out a couple of months ago that helped us understand how to manage people with these CHEK2 mutations even better, because depending upon where your mutation or pathogenic variant is in the gene can help us understand what your risk is, and maybe whether or not there might be elevated risk for prostate cancer, or maybe just a minor risk for prostate cancer. So the world's always changing in that. One thing I like to discuss is whether or not knowing this gene mutation can help us predict whether or not prostate cancer is going to act more aggressively, or whether or not it'll suggest that prostate cancer may not be super aggressive, may act like prostate cancer in the general population, where someone could be on active surveillance for 10 years and their prostate cancer never changes. So we don't know too much about HOXB13 at this point in time. There's some conflicting studies about aggressiveness, but we do know about the gene BRCA2 specifically. We know that individuals with BRCA2 gene mutations, their prostate cancer will always get aggressive. We know that if someone has a BRCA2 gene mutation and they don't have prostate cancer, we want them to be screened very carefully for prostate cancer. When it comes to BRCA1, it's sibling gene. There's conflicting evidence about aggressiveness. We think it's more aggressive, but because there's conflicting evidence, we can't be as conclusive with that. The Lynch syndrome genes, we're still trying to tease out whether or not having Lynch syndrome means that prostate cancer gets more aggressive. We know it increases risk, but we don't know if it makes prostate cancer more aggressive. When it comes to ATM, we don't know. I suspect that it might make prostate cancer more aggressive, but that's going to be determined in a few years. And then for CHEK2, we don't think that prostate cancer is more aggressive at this time. Well, what about treatment? And this is looking at the lens of active surveillance, surgery, radiation. Can knowing your gene mutation give your oncologist, your urologist, any insight into how to manage your care? There was one study that said that people with BRCA1, BRCA2, or ATM germline mutations that they inherited don't do as well in active surveillance. They're more likely to reclassify and upgrade on active surveillance. If you look into the data more, it really just focuses on BRCA2. The majority of people who reclassified or upgraded were men with BRCA2 gene mutations, and I think that they just dragged along the ATM and the BRCA1 people with them. So it's still to be determined. But one thing that we do know is that because BRCA2 gene mutations do cause more aggressive disease, if someone is an equally good candidate for radiation or surgery, maybe surgery might be a better option, because we can remove the prostate, do a full pathology review to make sure that we caught everything correctly, and then maybe even take some lymph nodes to see if it had moved around or spread. And this comes from me, who's trained by a radiation doctor who favors radiation. He's biased because that's his whole training, and he will push people towards surgery if they have these BRCA2 gene mutations and they're deciding between which method to use to treat. At this point in time, when it comes to active surveillance, when it comes to surgery, when it comes to radiation, it's the Wild West. There's no guidelines, there's no rules. We're just using what we see in literature to make decisions based on this point. There's no guideline at this time. The last thing I want to talk about when it comes to risk is metastatic prostate cancer that spreads. For individuals with BRCA1, BRCA2, or ATM gene mutation, there's a drug that targets and kills prostate cancer based on this, and it lets people live longer when they have metastatic disease. And so people who have metastatic disease, I want them to get genetic tested to see if they're eligible for this drug. There's another drug connected to people with Lynch syndrome that if we find that someone has Lynch syndrome, this other medication really helps with their treatment as well. So these are things that are on the radar of oncologists now to say, hey, if my patient has this gene mutation, I want them to get X, Y, Z. And so I also want patients to advocate for themselves to say, hey, I have metastatic disease. I haven't had genetic testing yet. I want to get that so I know what my options are. And we'll get to it. Okay, so why do genetic testing? Understand your prostate cancer risk? Great. A lot of people who do genetic testing have prostate cancer. They knew that their risk was 100% already. Potential risk for other cancers, colon cancer, male breast cancer, pancreatic cancer. That's another reason to get it done. Cascade testing for other family members. Some of these genes can help understand, really just BRCA2, help understand aggressiveness of prostate cancer. Maybe can give some recommendations for clinical treatment of localized disease. This is still the Wild West, no real guidelines on this, but it would make people eligible for PARP inhibitor medication, which is the medication that targets BRCA1, BRCA2, and ATM specifically. So how do we do genetic testing? There's a traditional model, and that is where a doctor refers you to meet with a genetics person like myself. We talk about what it means to get genetic testing done. We then facilitate a blood draw. A couple months later, the results come back. We talk about those results. This is the standard way of doing genetic testing, but because volumes are so much higher, because more people are eligible to get genetic testing done, we've used different models of care. This is a mainstreaming model where actually the doctor is the one who orders the genetic test. And then the blood draw happens, the results come back, and then the genetics center may follow up with the results. And so in some circumstances, your oncologist, or maybe in the future your urologist, will say, okay, let's do genetic testing on you at your consult. So you don't need to get a referral to a genetics clinic. You don't need to wait for that. You don't need to wait for meeting with another healthcare provider to talk with you about the result up front. And it just takes time, it brings the time down. I have my colleague Emily Thane. Is that bell for me? Maybe. The traditional model, this is what a referral looks like. They get this referral information to talk about how to initiate this process where you meet with a genetic counselor. The mainstream model, anybody who has metastatic prostate cancer is eligible to get genetic testing done on the germline. And so that's the other factor that we take into consideration, and that anybody can talk to their oncologist about, because the oncologist treating for their metastatic disease should be able to do that here in Saskatchewan. If someone's interested in genetic testing and they don't meet criteria for some reason, there are ways where you can pay for testing. The Screen Project is one of these beautiful ways. It's run out of Toronto, but they send a saliva kit to your home and you meet with a genetic counselor virtually. And the results can come back in 4 to 6 weeks if someone initiates that process. And anybody can do this themselves. They don't need a doctor to be involved. When it comes to genetic testing, people think about, well, listen, what if you do find I have a gene mutation? What if I've never had cancer? What about life insurance, critical illness insurance? Would they use this information against me? We're protected under the Genetic Non-Discrimination Act. No company that makes money off of your medical records can even look at your medical record. And they're all afraid to, because they would get sued, and there was one litigation in this way. Insurance companies can still use your personal history and your family history against you. They just can't use your genetic test result. So this is a good protected result. These are all the things I want to talk with you about. There's a lot. But hopefully if there's any kind of questions in the Q&A, we can hash through some of these things. But a new world, a new frontier for care in prostate cancer.
Justin, thank you very much. That was a lot. And I'm 40 years out from a genetics course, and so I appreciate the refresher. But now I need that refresher in my practice. You know, Justin mentioned that there will be more genetic testing going on. Some people in this room may have had it done already as part of their diagnosis and treatment for prostate cancer. I'll also let you know that the pathologists who look at the biopsy, the tissue specimen that Justin referred to, are already doing genetic testing. So in some circumstances, if a biopsy shows a certain type of high-grade or very malignant prostate cancer, then that tissue is automatically sent for genetic testing. And in some cases, your medical oncologist, who you may think of as your chemotherapy specialist, but your medical oncologist is already ordering that testing. And in Saskatchewan, as in many places across the country, we do have access to the other medication that Justin mentioned, the PARP or the PARP inhibitor. So this is very timely. It is going to affect men and their families, not only as far as treatment, but what do you tell your sons, grandsons, nephews, brothers? So thank you for that. Really timely talk. And a challenging subject, but you made it really clear, so thank you for that. Thank you. So after that, we do have another keynote speaker, but I think we should get the blood flowing a little bit. And so I want to invite Shannon for a stretch break. You may remember that we started doing this stretch break a few years ago, and it's helped me. I can only say that. Shannon is from the First Step program. The First Step program is a partnership program between the City of Saskatoon Recreation and Community Development Department and the Saskatoon the Saskatchewan Health Authority Chronic Disease Management. And the program's aim is to provide high-quality prevention and rehabilitation to people with health concerns in and around Saskatoon. So, Shannon, I invite you up to the stage. You and I will the stage work for you? Yeah. Do you want to say anything else about your program? You're the expert on that. Do you have something to say about it? Please.
Although this is going to be at my forehead, so I'm a little smaller than most people. So I represent the First Step program, and the program is not only for people with chronic disease, but it's people that want to prevent it. So maybe the only thing they have is, I'm inactive and I can't seem to get started again. That's a risk factor. So they're welcome to the First Step program because they want to prevent high blood pressure. They want to prevent other things. The First Step program also has certified exercise physiologists. So you basically have an exercise therapist providing you with exercise, with questions you might want answered. And like what's being said today, if someone has any type of condition, whether it's prostate cancer or other cancers or other conditions, it not only affects you physically, but it affects you mentally. It affects you that, oh, I'm thinking about this all the time, so I'm not getting enough sleep, and I'm feeling tired all the time. Might be from treatment, might be just from I can't stop thinking. So getting exercise not only helps with your physical and your health well-being, but your mental health and just dealing with that fatigue that you might be feeling going through treatment or just after treatment or just trying to cope with that, all of a sudden having that C word, right? So I'm going to get you guys moving. And
where will we find the First Step
yes,
program?
So the First Step program is ran at the Field House. So everybody probably knows where the Field House is. It's across from the university, right beside Merlis Belcher, the new fancy skating rink. So the First Step program involves walking. I put on all the tables the 6-step example of basically what's involved with the First Step program. So the first step is just phoning or just dropping off an application. So people that phone me, it's like, you guys have all done this. You think about something, you're like, oh, I'm going to try it maybe in a month or maybe next year. And you think about it and you don't do it. And then you think about it again, but you don't actually follow through. So this is like compared to many, many, many things in our lives. By the time someone phones me, they've thought about it for months, years, and they finally got the courage to phone. So that's the first step. So it's not even getting in the program, it's actually phoning or actually bringing in the application. So I have application forms on my table. So that might be one of the barriers, like, I'm going to make myself go down and get that application form. And it never happens. So the phone call is usually after months of thinking about, I need to get active, I need to get moving again. But maybe after COVID, I haven't got out and I'm not sure. So getting that phone call in and then talking to me, and then I'm just going to pull out any fears that you have and go, okay, you know what? We're here to support you. We're here to get you moving. And we're here to help you in your healthier lifestyle. So calling me, the number is on the, actually there's a QR code on that First Step little paper there. And that'll give you more information about the First Step program and about how we do have that partnership with the Health Authority. And the partnership is really important because everybody that comes to the program not only have access to exercise therapists on the city side, so being me, and exercise therapists on the Health Authority side that deal with all sorts of different chronic disease. So it's way better than just the weekend warrior person that maybe learned a little bit about exercise or they go to the gym once in a while. So let's get you moving. All right.
I'm going to
So-
join you up here.
Okay.
Thank you, Shannon. So, I am pleased to introduce our next guest speaker, who you've kind of already met a little bit, because we heard about Dr. Nelson Leong, and he's here today as a medical expert, but we've already heard a little bit about his caring ability and the personality that he brings to his patients. So I'm pleased to introduce to you Dr. Nelson Leong, who is clinical assistant professor with the University of Calgary, and he's originally from Calgary. Very recently, Nelson moved back to Calgary with his wife and new baby, 4 months old, 5 months old? 5 months old. So he has left them at home, I believe, and he's come back to Saskatoon. And he used to work in Saskatchewan as an associate professor with the College of Medicine at the University of Saskatchewan. And we were sad to see him go. He received his medical and residency training in radiation oncology at the University of Alberta in Edmonton. He completed a research fellowship in patient-reported breast cancer outcomes and prostate brachytherapy at the Victoria Cancer Centre in British Columbia. He has a special interest and a Master's of Science in clinical informatics and is always keen to adapt new technologies to improve the patient experience. Nelson's talk is entitled High Dose Rate Brachytherapy. And Nelson, I welcome you back to Saskatchewan. I welcome you to the podium. Thank you.
Thank you, Kishore. It's a pleasure to be here. Thank you so much for inviting me to talk, and it's really nice to be back in Saskatchewan. It's really sorry I couldn't be there for Dawn's implant. I had just started paternity leave, and so I'll be honest, that little stretch has been the most exercise I've done in about 5 months, so bear with me if I'm a little out of breath. I just wanted to thank the Alan Blair Cancer Center. So a lot of these slides were made in conjunction with the team. Also, some of these slides I kind of borrowed from Dr. Morton. He's a brachytherapist who actually works at Sunnybrook. And a lot of our program is based on his work and his techniques. So we've really learned a lot from him, and some of these slides, he was kind enough to allow us to use some of his photos. Okay, so disclosure slide. The too long didn't read version, I don't own any stocks. I'm not in any crazy advisory boards. I have received a few speaking honoraria before, but nothing we're talking about today should interfere, should conflict with any of my other engagements. So that's me. So I've been across Western Canada a lot. So I've worked in Victoria, Edmonton, Calgary, Vancouver for a little bit, and Regina. So being all over. I usually show my two research assistants. So they helped with the making of this this slide deck. They actually wouldn't leave me alone the whole time I was making the slide deck. Now, I'd just like to bring up, if it's going to be hard to read, it's a little flickery, but Basically, I'd just like to outline that what we're talking about today is a very kind of general outline of HDR prostate brachytherapy and where that might fit into some of the treatment strategies that we might use for prostate cancer. The important part, though, is that the best care that you're going to get as a patient and also as family members who are supporting patients is usually a one-on-one consultation with a physician or your medical team to make personalized healthcare decisions. So this is a really good general overview, and I am a doctor, but just remember that I'm, with the exception of Don, probably not your doctor. So we're going to talk about a little bit about some of the treatment options that men have available for localized prostate cancer. So we usually divide cancers into localized, so cancer that hasn't spread, and then advanced cancer. So today's talk is mostly going to be focusing on the localized cancer. I'm going to talk a little bit about the program that we have running at the Alan Blair Cancer Center in Regina. And I'm still going to use we because I still talk like I'm from Regina. Every time I talk to patients, it's still in Calgary. And then I'm also going to take some of our data that we were collecting about our outcomes, so cure rates and side effects and toxicity. And so we actually have some data that's local to Saskatchewan so we can tell how our program's doing. So feels like I'm preaching to the converted, but prostate cancer, it's really, really important. It is the most common cancer in men. And so even when you don't take sex into account, it's still one of the main most prevalent cancers. And from an impact standpoint, prostate cancer is lost the slide, but I believe the third leading cause of cancer-related death in men. So it's behind, I think, lung cancer and colon cancers, so it's number 3. So it's really, really important, and it makes a huge impact on a lot of men's lives. So one of the first things that we do when I'm having a consultation with a patient is we have to divide men into risk categories. So it's a spectrum, but as doctors, we like to put things into buckets. And that risk categorization tells us a few things about your risk. So first, what's the risk that this prostate cancer does something nasty if we don't treat it? So by nasty, I mean get worse or start causing problems or issues locally, or the worst case scenario, spread to other places in the body or even shorten your life expectancy. But the other part of the risk category tells us what is the risk that this cancer comes back if we don't treat it with enough stuff. So the risk category first tells us, should we be treating this, or is this something that we can just monitor with active surveillance or just watch for a while? Because many prostate cancers that are low risk may not actually need treatment. And then if we do need to do treatment, how intense do we need to be? Because we want to balance. We want to give you enough treatment so that we're actually getting the job done and the prostate cancer stays gone, but at the same time, we don't want to leave the scorched earth, and we don't want to leave men with more side effects than they needed to actually accomplish our goal. So most of the patients that I would see for brachytherapy fit into the intermediate or the high risk category. And the nice thing is if you look at the spectrum, so there's a few things that we look at. So your stage. Staging is mostly clinical, so despite the fact it's the 21st century, staging is usually done with the finger. So that's why even with PETs in the era of PET scans, MRIs, CT scans, your doctor is still sticking their finger up there and feeling things, because it's still an important part of trying to determine your risk category. So it's there's a reason why we keep doing that to you, and I always tell patients I'm sorry. The second thing we look at is your Gleason score or your grade grouping. So that's where a pathologist looks at the prostate cancer specimens and kind of gives it a rating from, I use grade groupings because they run nice and easy, from 1 to 5. 1 being just barely looks like cancer, to 5 being like, oh, that looks a little bit nastier. And then the last thing that we do is we also look at the PSA. So when we take those 3 things in combination, we're able to assign a risk category and counsel patients on what treatment options they have available. So if you have an intermediate risk prostate cancer, so the good news is if you look at kind of the graph of all the different treatment options, as an intermediate risk prostate cancer patient, you would have a lot of treatment options. So that's the good news. The bad news is you've got a lot of treatment options. And choice paralysis is a thing, and so that's something that we try and navigate with patients. But our focus today is mostly going to be about how does brachytherapy fit into all this. So just to talk a little bit about brachytherapy, it's I say brachytherapy, I think the Americans say brachytherapy. I believe either is right because I don't actually speak Greek, but it's so brachy or brachy comes from the term short ranged or short, close in close distance, and the idea behind brachytherapy for any part of the body for treatment of cancer is that we're putting a radioactive source, so whether that's seeds or pellets, or in our case, a little high-dose radioactive source, or back in the day they used to use pastes, but we're putting it right against the cancer. So we're using geometry and we're using close proximity to get us the best treatment possible. All right, so just some historic slides. So brachytherapy has come a long ways, and I'm going to show you what a modern day implant looks like. But back in the day, they used to take a little chunk of radium or radon that was just at the tip of the needle, and yes, an oncologist would actually stick their finger up the back passage, and they would just kind of fish around with the needle and try and hold it in the prostate for a predetermined amount of time. So as you can imagine, that wasn't quite as precise, and for the oncologist, it's probably not great either because that's a lot of radiation that your hands receive. So they tried to figure out a different way. So the next step was to start, could we take these little chunks of radon and actually start leaving them behind? So that was kind of the first seed implant. Well, we've come a long ways since then, and so we have a few modern day improvements. So now we use newer isotopes. So radon, it was one of the first radioactive materials that we used for treatment, but now we have other isotopes that we can use that work faster or have better characteristics to them. We use technology to try and localize the prostate a bit better, so we use fluoroscopy units, so those are X-ray machines, but also ultrasound machines to direct our therapy. We use a technique called afterloading, so that's it's mostly for actually everyone else who's doing the treatments, but instead of having this live needle that you're sticking in there and trying not to get radiated, well, you can put the needles where they need to go. And just like when your dentist runs around the corner when they're doing your x-rays, we all run out of the room, leave the patient in the shielded room, and then the radioactive source comes out of a safe. So really, the only person who gets exposed to the radiation is the person who actually needs the radiation. And then we also have this new technique called inverse planning. So now we can use computers we tell the computer what we want, and the computer actually figures out what's the best way to hit the target. So there are two main kinds of brachytherapy that are used for prostate cancer. We have low dose rate brachytherapy, so that's the implantation of seeds. A lot of my patients are very super keen to come in and hear about it, but the challenge with the seed therapy is that it's only helpful for a very, very select group of patients, because if your risk category is too high, the seeds aren't going to stretch far enough to do the job. And if your risk category is too low, well, then you probably didn't need the seeds anyway. So it's actually a very, very small kind of Venn diagram mixed, juncture of patients that actually can benefit from it. The high dose rate brachytherapy that we're talking about today, the idea behind it is that we would be implanting some of the hollow needles directly into the prostate gland, and then that radioactive source is afterloaded into the gland, and then a nice high dose of radiation is delivered into the prostate. That's still going to, for most cases, be followed up by some external radiation, because just like the seeds, one of the nice things about the brachytherapy, it's a very confined area of dose, but one of the bad things about it is that it's a very confined area of dose. So you do need the external radiation to kind of mop up anything that doesn't get covered by the brachytherapy. In Saskatchewan, the procedure is done under general anesthetic, so patients are blissfully asleep for the whole thing, and the whole thing takes about 4 hours start to finish, but the actual kind of go time is only about 20 to 30 minutes. The rest of the time is actually spent putting the needles where they need to go and doing all the calculations and all the legwork for it. So men who are being treated for prostate cancer at the cancer center with radiation are generally going to see one of these two units. So the machine on the left is a linear accelerator. So that's one of the machines that produces external X-rays. And so we'll usually use those for men who are getting radiation. And then the brachytherapy is provided using the machine on the right. So that machine is hooked up to those hollow needles, and then a little guide wire will actually drive the radioactive source up into those needles and dangle it there for a few seconds, and then kind of do that for each of the needles. So the end goal is to produce some radiation. So these are just kind of pictures of men's prostates. So just for orientation, they're little CT scan slices. So imagine that there is a person laying on their back, so their head's going into the screen, their feet are coming out of the screen, and we've kind of sliced them like a bread loaf. So we're just kind of taking a look at one slice. So the treatment on the left is a brachytherapy. In this case, we used a seed implant just for demonstration purposes. And on the right is a stereotactic radiation treatment, so a high-dose external treatment. So the lines that you're seeing are various, the medical term for it's isodoses, but they're basically the levels of radiation and how much we've been able to deliver. So the 100% line, which is labeled in, I believe, green in both cases, that's kind of the target goal. So that's how much radiation we were prescribing or planning to treat. So both treatments do actually a really good job of containing the prostate and the prostate alone with that 100% line. What's different though is that brachytherapy, because whether you're using seeds or the high dose rate source, it's such a short-ranged radioactive dose that it falls off really quickly. So the 50% isodose line, which is the yellow one, is still pretty close to the prostate. Whereas for the external radiation, because the X-rays that we use, they all travel in straight lines, and for the most part, they fall off kind of in a straight linear fashion. So you kind of, some gets deposited a little bit in after it coming in the skin, and then a little bit gets dropped off as it continues to travel along in a straight line. So there's going to be a lot of exit dose. So the nice thing about the brachytherapy is that we're just able to keep more of the radiation where it's supposed to go, and allowing us to do that is what medically allows us to push the radiation dose to be able to put more radiation in without worrying as much about side effects. So we're going to take a little bit of a brain break because that was a lot of information. Quick quiz question. So the linear accelerator, the previous version of that was actually a radon radiation machine, and they were revolutionary at the time because up until then, X-rays that we were using didn't go very far into skin. So this radon machine, when it was invented, was amazing because now you were getting X-rays that you could send into patients, and they would go much deeper, and you could now treat things on the inside like prostates and lungs and other things that weren't on the outside of the body. So, question: what were the first two cities to house a cobalt radiotherapy unit? So where were they invented? Saskatoon. So someone's done their research. Saskatoon was one of the cities, and then London, Ontario was the other one, and they argue back and forth about who actually had the first machine. I think they were actually almost done pretty much at the same time. I think the Ontario one was the first one used clinically first, and then I think the Saskatoon one was the first one to just be used in general. So a little bit of history, so that's really cool. So just kind of switching gears and talking a little bit about the treatment program at the Alan Blair Cancer Center. So we have a little Phoenix because the HDR program is actually, it's new, but it's old. So it was running for quite a while, and there was a short hiatus short of maybe a decade, I think, where they stopped doing it for a while, and then back in 2015, they started the program back up with all the new technologies and all the new benefits we have with the new machines. Currently, the program runs about once or twice per week, so the throughput's usually 1 or 2 patients per week. Last I checked, there were 3 brachytherapists in Regina, and patients from either cancer center are eligible for treatment there. So we all work together. So I was just going to show some of the equipment that we use. So on the left is kind of a stylized version of the ultrasound probe, the little template that we stick on top to guide the needles, and then just kind of where all your organs sit. And we'll look at that in a little more detail shortly. I have a video. I have no idea if it's going to play. It's always kind of like a little bit of a lottery, but oh, hey, that's actually cool. So short video. I believe this was put out by the actual company that does brachytherapy, but I'm not sure because it's been reposted so many times that the original source has been lost to antiquity. But the idea is that there's an ultrasound probe inside the rectum, and then the prostate then has needles directed through the perineum directly into the prostate. Those hollow needles, we take the metal parts out and they just turn into flexible tubes or catheters, and then we hook that up to a radiation unit. The little green thing that's running through right now, that's the check cable. So, we want to make sure that all those tubes are actually open and free before we actually start sending a little radioactive source through. The little radioactive source comes from the safe, goes up into the tubes, and then the computer, using that inverse planning method, determines how long to hold the source at each position inside the prostate. So the prostate, as it kind of steps through, gets treated through each of the catheters that's inserted. The nice thing about using the inverse planning is that if the needles don't necessarily wind up exactly where you wanted them to, the computer is usually able to compensate by leaving the source in a certain position for either longer or shorter. So the end result is that you get a really nice high dose of radiation delivered to the prostate. At the end of the procedure, all the needles, all the catheters, everything comes out. So as Don mentioned, you're not radioactive afterwards. There's unfortunately no glowing in the dark and no special powers. So even though they're very, very different treatments, a lot of patients ask me, like, what's the difference, why aren't I getting seeds, or what's the difference between the seed therapy and the high dose rate brachytherapy? Well, the one advantage of the seed therapy is that for that very select group of patients, it can be a one and done treatment, right? So you come in for your procedure, they drop the seeds off. They're technically cheating because the seeds are actually treating you for 3 months, so it's not actually like a single treatment, but you only have to come in the once. The seeds are permanent, so we don't ask for them back, and they are radioactive, so they give off the radiation over a period of time, and that's important because there's some safety considerations, but also from a side effect standpoint, it kind of makes sense that if you're still getting radiation, you're still going to have the side effects. So the side effects of the low dose rate brachytherapy actually stretch on a bit longer. The other thing is not to knock the seeds, because I used to implant them as well, but it is technically challenging. So the seeds don't always wind up where you really wanted them to go. So there's always the risk that if the seeds kind of move or they don't all get dropped off where you wanted, then sometimes you might have more or less radiation in certain parts of the prostate. Whereas with the high dose rate, since the computer's controlling it, you know exactly where that radiation dose is going to wind up. So typically, the high dose rate brachytherapy is a little bit more consistent, a little less operator dependent. There's no radioactivity left within the pelvis. Kind of some of the downsides, though, is it does take a little bit longer because you're trying to do all that planning and stuff while your patient's on the operating table. And for the most part, our high-dose rate brachytherapy needs to be combined with another treatment. So, a single shot of high-dose rate brachytherapy, because it's all in one go, usually isn't enough to get rid of prostate cancer on its own, so it needs a little extra. So when we're selecting patients, we try and ask, well, which of our patients are going to benefit from this technology? And generally, it's patients who have higher risk disease who are going to benefit from the higher dose of radiation therapy. So these are going to be men who have intermediate or high risk disease. I'm not trying to be ageist, but typically younger patients or men with longer life expectancies, and we'll explain why that's the case in just a bit. And men who have a higher burden of disease. So if you've got low risk prostate cancer or even that low intermediate risk, the high dose rate brachytherapy might be a bit of overkill. So we also need to make sure that patients are good candidates when they come in for a consultation. The prostate cancer has to all still be localized within the prostate, which kind of makes sense. If you've got prostate cancer that's spread into the bones or somewhere else, all the radiation in the world to the prostate's not going to fix the problem. We do want patients to be, like I said, high enough risk that it's going to provide a benefit. Generally, we're hoping that prostates are going to be small enough to be easy to implant. So in general, your average prostate is about 30 cubic centimeters, so about the size of a shot glass. Most men with prostate cancer have larger than average prostates. That's just kind of the way it goes. But if a prostate gets too large, then it starts getting more difficult to try and get the needles in where we need them to, because the pubic arch or the bones of the pelvis start getting in the way. So the size cutoff that we have, it's not an absolute cutoff. It really depends on, how big is your prostate compared to the rest of your anatomy. So if you've got a small, tiny guy, but a big prostate, that's going to be a problem. Whereas if you have like a giant Texas-sized guy who's, kind of big and stocky, sometimes the bigger prostates are still going to be okay because the bones aren't going to get in the way. And then from a medical standpoint, patients should be able to tolerate the anesthetic. So in Saskatchewan, at least, they're all done under general anesthetic. Right now, local and spinal anesthetics aren't really being entertained just because there's a lot of technical challenges involved with trying to implant someone who's still awake. And then life expectancy, like I talked about, we want patients to be around long enough to actually see some of the benefits of the treatment. And then currently, treatment in Saskatchewan is reserved for patients in Saskatchewan, so I don't think we treat anyone else outside unless there's a very specific reason or they kind of live right on the border. So our workflow, like I mentioned, is about 3 to 4 hours. There's a lot of steps involved with actually doing the brachytherapy, and I thought I'd just outline them really briefly. So we work as a really big team. So sometimes men are a bit surprised when they come in because the room's pretty busy. There's like 6 or 7 people in there between the anesthesiologist, the physicist, your radiation oncologist, a couple nurses, a couple therapists. So big team of people all working together to make sure that that radiation treatment goes off without a hitch. Sometimes it's a little bit intimidating, and we apologize for that. So the first step is just patient selection, making sure that that a patient's appropriate for the general anesthetic. We're not going to run into any problems like unforeseen sleep apnea or heart problems. We give them a lot of information about cleaning out the bowels because nothing slows down your day like having a poop chute full of poop getting in the way. And then we also use a medication called tamsulosin or Flomax before to kind of reduce the risk of inflammation and problems with passing urine afterwards. So on the day of treatment, so Dawn's story is pretty common. So most men will show up first thing, crack of dawn, 6:30 usually is when they check in. They do all the preparation work, so cleaning out the bowels, attaching all the stockings and things to keep the blood flowing. They start an IV. We do insert a Foley catheter, so that's a tube into the bladder as well, but we change the process, so now we wait until patients are asleep before doing that, and we've gotten really positive feedback about that. So men really appreciate that. So yeah, I'm getting a thumbs up, yes. And so on the tray, so we use a lot of tools. So we have a lot of towels. I go through a lot of towels. We have the catheters, the pilot needle that we use to just kind of break the skin. We have the template and the ruler. Now, some of the photos I'm going to show you coming up, they're from a volunteer patient, and they're all gowned and draped and everything, so you can't see anything. But we are going to see body parts, so I'm just throwing out a trigger warning in case that upsets people. This is your chance to go get a coffee. So we do the general anesthetic, we prep and drape, then we clean everything, and then we insert this ultrasound probe into the rectum. We then take some ultrasound pictures of the prostate. So on the left, we've got another bread loaf slice. And on the right, we've got a slice, same person, but sliced kind of this way. So we're looking at them from the side. And the orange there is the prostate. So in both cases, so we're looking at it from the end on and then from the side. And that little green thing that's been drawn is the catheter or the urethra that goes through. And that's pretty important to know where that's at too, because it's pretty sensitive to radiation and we need it to pee. So the next step is inserting the catheters, and we kind of joke that sometimes it is like Battleship. So it's a grid, it's labeled with letters and numbers, and if patients were awake, they would hear us just calling out letters and numbers for about 30 minutes straight while we're inserting things. But generally we try and follow a template so that most of our needles are going to wind up on the outside of the prostate where we want most of the dose to go. We send a few to the inside just to make sure that everything gets nicely covered, but we try and leave a space around that urethra, again, because it's pretty sensitive to radiation. So we're going to, so using that ultrasound, we slowly insert the needles into the designated positions. And this kind of demonstrates, what that might look like as we build that the sets of needles up. So kind of going chronologically from left to right. Usually we work from the top of the prostate or the front or anterior edge to the posterior. And that's just because the ultrasound, if you put things in the way, it starts getting hard to see. So we start the farthest away from the probe and just kind of work our way towards the bottom. After we have all the catheters in place, we take one final picture of the prostate, and then the oncologist sits down and starts trying to draw out all the targets that we're trying to hit or avoid. So that includes things like the prostate, that's in red, the urethra, which is in yellow. Oftentimes we'll also draw out the rectum. I actually did draw it on that one. So it's the rectum in purple, and then sometimes the bladder as well. While that's going on, our physicists and our therapists are busy taking measurements of how much of those catheters are sticking out from the template, and we use that information and we put that into the computer so the computer knows exactly where in space every single one of those catheters are, and it also knows exactly how far in the catheters are sitting. The next step is that the physicist and the therapist will sit down and try and reconstruct where the catheters are. So now that we've put all these catheters in, we have to tell the computer where they are all sitting. So this is probably actually the longest part of the implant because most of the catheters are easy to see, but some of them, especially if they're hiding behind other catheters or they're getting shadowed by things, sometimes it can be a bit more difficult. So they have to take a lot of care, and there's usually two people involved just to make sure that they both agree with each other because we want to be really sure that we're hitting the right spot because you can't take the radiation back. After we know where all the catheters are, we do that inverse planning. So we tell the computer, here's a prostate, I'd like it treated. Here's a rectum, please don't toast that. Please don't toast the urethra either. And so the computer runs through a bunch of different options, and then it selects the option or the solution that gives us the best possible coverage while minimizing all the radiation to all those things that we don't want to hit. So the planning system that we use gives nice green lights when all the kind of objectives that we've asked it for are met. So in this case, we had a really, really nice treatment plan. The main goal is to try and get as much radiation as we can to the outside edges of the prostate, because that's where most of your prostate cancer will sit, but still sparing the inside where the urethra sits. After that, we hook the catheters up to the radiation unit, and we double check to make sure that everything's connected correctly and that the right catheter is connected to the right tube. There's a lot of quality assurance. So like I mentioned, you can't take radiation back. So we're so careful about making sure that everything's being done correctly. So every contour in Saskatchewan is double checked by a second radiation oncologist before being signed off. The plan is looked at by the physicist, the therapist, and the oncologist. And there's a lot of double checks done in the background to make sure that from a technical standpoint, the machine's actually doing what we've asked it to do. Finally, after all of that, we get down to business. So everyone else runs out of the room. We have cameras that are set on the patient so that we can just monitor the anesthetic and make sure everything's going okay. And then the big safe door closes and we remotely activate the radiation and it carries out the plan. So that whole thing takes about 15 to 30 minutes, just depending on how big the prostate is, but also that radioactive source. Depending on how fresh they are, they are more active when they're newer, so that actually also impacts the treatment time. After the treatment's done, we open the doors up, everyone rushes back in, and we get those catheters out as quick as we can. After the procedure, patients are brought back upstairs to recover, so the general anesthetic is allowed to be reversed and wear off. As soon as patients wake up, we usually take that Foley catheter out. And when they can demonstrate that they're able to walk okay, that they're not having any issues from the anesthetic, and they can pee, we usually discharge them home. There's a couple kind of logistics things that we usually discuss with patients. So People can get kind of squirrely on anesthetic, so we usually insist that they have someone to stay with them overnight. And then obviously you don't want someone to be driving right after they've had an anesthetic, so if you're coming from, especially if you're coming from Saskatoon, you do need someone to drive you back home. So generally we have follow-up the next day with the brachytherapy team just to make sure that everything went okay, there were no surprises, the urination's still going well overnight, pain's well controlled. A couple weeks after that, the external beam radiation would start, and if you're from Regina, then you get it in Regina. If you're from Saskatoon, oftentimes the radiation therapy is just done up in Saskatoon. So what are some side effects of the treatment? So it sounds great, but there's always some fine print. So in the short term, men who get radiation can feel tired, so almost like they need to take an extra nap or they spent some extra time out in the sun. Anytime we stick something sharp into people, there's a risk of bleeding or infection. There's also a risk from the anesthetic themselves, but that's kind of the anesthesiologist's deal. Sometimes you can get some discomfort in the perineum or some bruising. A lot of times it can be managed just with an ice pack or ibuprofen. The radiation itself can cause swelling or irritation of the prostate, and that can sometimes put pressure on the urethra, which is the tube that carries urine out into the rest of the world. So if that gets blocked up or squeezed, it can be hard to pass urine. So about 5 to 7% of our patients, so about 1 in somewhere between 10 and 20, will unfortunately have enough irritation that we need to put the Foley catheter back in just to let things settle down a bit. And then the radiation in theory can also cause irritation of the bowels, although most of that's actually probably going to come from the external radiation portion. So just for interest, these are actual real world numbers from our Saskatchewan program. And so we have this grading system that we can use for grading side effects. So grade 0 is, the green, no problems whatsoever. Yellow is grade 1, so, people mention something, they've noticed a change, but not necessarily interfering with their day-to-day life, and it doesn't really bother them. Orange is usually, hey, this is bothering me to the point that I need to take some medication for it, or it's really troublesome. And then red or grade 3, so that's something that needed, a medical intervention. And in most cases, it's going to be a catheter. So on the left, we have the urinary issues, and on the right, we have the bowel irritation. And these are measured at the end of the radiation therapy, so right at that last week of the external radiation. So what we pulled from this is that there's a questionnaire that we give to all of our patients. We call it the IPSS or the AUA. So it's a prostate symptom score of things like how hard, how much do you have to strain to pee, how often do you have to go to the bathroom. And so about 35% of our patients would notice in the short term that they had scores that were at least 6 higher than what they had coming in the door. And why do we pick 6? We have to set a threshold somewhere. So that's sometimes considered a reasonable number for a clinically significant difference, so enough that it might bother somebody. In the long term, anything that sees the radiation can be damaged or changed by it. So most of those short-term side effects that we talked about, they're transient and temporary. So as that swelling goes down, the radiation irritation goes down, usually by about 6 to 8 weeks after the radiation therapy, things are back down to the new baseline. But radiation can cause changes or damage to normal tissue, and those changes can cause permanent or long-term side effects. Now, these side effects, interestingly, don't show up until more than 6 months after treatment, sometimes not even years until after the treatment. So what sorts of things can happen? Well, you can have scar tissue in the prostate, which might make it harder to pee. You might have permanent try not to pop my peas as much. You might have permanent irritation of the bladder, which maybe makes it more irritable. You can't hold as much urine before needing to go to the bathroom, or when you gotta go, you really gotta go. In rare cases, we can cause bleeding from the bladder. Medical term for that's hematuria. Bowel changes. So most guys will say that after the radiation, they notice a bit of a change, but not necessarily horrendous. But some will notice more troublesome or bothersome changes, like, to be clear, it's very rare for men to die of loose poop in Canada, but that doesn't mean it can't be really irritating and frustrating. You can have some there's some small risks of some very serious things like holes in the bowel or holes in the bladder or cancers from radiation. Thankfully, those are really, really rare. And then there's also the sexual dysfunction piece. So in terms of late toxicity, we grade them the same way as we grade the acute toxicities. What we can see from this is that, that most of those early toxicities will settle down. So from a urinary standpoint, most of our patients are actually doing well. So about 50 to 60% of them will have either grade 0 or grade 1 toxicity. So just, noticeable but not necessarily impacting quality of life. About 30% of our patients reported grade 2 urinary bother, but about a quarter of those people had those toxicities even before they had the radiation, so they had some pre-existing issues. And then about 6% of patients would have what we would call a grade 3 toxicity, so again, needing things like catheters or asking one of our urologic colleagues to go in there and kind of open up a passage. And then the grade 4 toxicity we've had, thankfully, knock wood, only 1 or 2 to date. And those are usually major things like holes in the bowel or bladder. From a bowel standpoint, usually things are very, very well tolerated. So much better than with just the external radiation alone, and that kind of makes sense because we're able to keep that radiation so confined that we're keeping a lot of it off the bowel and the rectum. So why do we go through all these hoops? Well, we're hoping for better outcomes, and there's a lot of different ways to measure success or measure outcomes. So the first one that we usually look at in clinical trials is survival. Are people living longer because of our treatments? With prostate cancer, though, it's not always the best landmark to use, though, because many of our patients will live a really, really long time, even if they're having prostate cancer or even suffering from prostate cancer. So we have to look at other measures as well. So there are things like disease-specific survival. So what's the chance that you died of the prostate cancer versus died of something else or didn't have the cancer come back? Metastasis-free survival. So what percentage of our patients are cancer-free and didn't have cancer spread into the bones? Because that's a pretty major event. Biochemical-free survival. So what percentage of our patients didn't have their PSAs come back up? And then freedom from toxicity, because we want to make sure that you're not just alive, but you're also living a life that's worth living and that you're feeling well and not having a lot of undue problems. So there's some data that we have about comparing external beam radiation therapy just on its own, so X-ray therapy to external radiation combined with the brachytherapy. And I'm just going to preface this by saying that most of these studies are actually a little bit older. So we now use, everything's always getting better. So the brachytherapy is getting better, but also the external radiation is getting better too. So most of the data, because it takes so long for us to collect and actually see a difference, most of the data that we have reported out to us are using techniques that are 15, 20 years old. So kind of take everything we say with a grain of salt, but what we're looking at here, I'm going to turn you all into scientists. This is called a Kaplan-Meier curve. And the way that these work is that on the left, we've got percentage of people who are biochemically free of evidence of that prostate cancer having come back. And on the right is, the left was the LDR and right is HDR. So what the curves kind of show is everyone starts at 100% because you don't have evidence of the prostate cancer having been there at the time of right after your treatment. But if you're shown to have that prostate cancer come back, then you're no longer part of that group, so the curve will drop down. So basically, being higher on the curve is better, because that means that at a given point in time, from 0 to 10 years, you were more likely to not have that evidence of the prostate cancer come back. And what this was trying to show is that in both cases, LDR and HDR, there seems to be a benefit to adding brachytherapy. This is another paper that kind of compared the combination of brachytherapy with comparing it against just radiation therapy alone. Now, usually when I talk to patients about this, the important thing to notice is that at least for the first 3 to 5 years, you'll notice that the curves are right on top of one another. So there's not really a difference between the two. So one of the important things when I counsel patients about brachytherapy is that for the first 5 years, there doesn't seem to be a really big difference compared to external radiation alone. So what that means is that if you have a lot of other medical problems, so let's say diabetes, heart disease, kidney failure, anything like that, you may not see the benefit from this if something else gets you before that 5 years is up. So when we say that we prefer to treat younger patients, it's not because we're ageist, it's because we're always trying to do these calculations and make sure that you're getting the bang for your buck if you're going to go through the extra side effects and hoops of getting the brachytherapy. This is also some local data, or this is some Canadian data from Vancouver, again comparing brachytherapy against the external beam radiation therapy. This particular study used seeds though, in combination with external radiation. But the Coles Notes version is that, past 5 years, there does seem to be a bit of a benefit to intensifying your treatment with brachytherapy. We haven't had as many studies done with high dose rate, but we infer that those benefits that we see with the seeds, we're also going to see with the higher dose rate brachytherapy. Whoops. And, this is some local data from Saskatchewan, and we don't have long enough data yet to draw those fancy Kaplan-Meier curves because the follow-up for most of our patients is going to be pretty short because we only started the program in 2015. But if we lump everyone together, we can see that we were able to determine that we had only about a 7.5% recurrence rate. Now that's going to be a bit lower than the real recurrence rate because that also includes patients who just got treated or just got treated in the last year or two. So as we follow patients longer, we expect that number to go up. But a 93% cure rate, at least right now, doesn't seem too bad. Most of our patients that recur tend to be, more of them were in the unfavorable intermediate or the high risk, so higher grade groups certainly was a risk factor for being more likely to have their cancer recur. So hopefully we've talked a little bit about the brachytherapy option compared to external beam radiation, and we've kind of chatted a little bit about what some of those benefits might be and also some of the pieces that go into our decision making when we're trying to counsel patients. Again, just to summarize, there doesn't seem to be a really big difference, at least until out past 5 years, and that's important for counseling patients and helping with that shared decision making. What I do try and impress upon people, though, is that brachytherapy from a PSA standpoint seems to be a bit better than just the external radiation alone in that 5 to 10 year mark. Now, to be clear, no one dies of high PSA. It's because the PSA itself is not harmful. It's what does that PSA represent. So we still need more data and research to prove that the brachytherapy will improve your chance of not having the cancer spread into the bones, maybe decrease your chance of dying of prostate cancer, but those benefits are going to be much further out, so probably more than 10 years after the treatment. So that's, again, important for our decision making, but also from a clinical trial standpoint, that's why we don't have that data yet, so we still need to keep studying and keep learning. So a lot of patients do ask me, okay, well, if we can do seeds once and call it a day, why can't we just do the brachytherapy, the high dose rate brachytherapy once and then just use that on its own. And the challenge with prostate cancer is that it's a slow growing cancer most of the time, but a lot of that cancer at a given time is going to be inactive. And when it's inactive, the radiation that we provide doesn't hit it quite as hard and it's not as effective. So we're most effective when that prostate cancer is actually actively dividing or doing something. So in some ways, prostate cancer growing slow, it's a good thing, but it also makes it hard to kill because it's only kind of vulnerable during a certain period of time. So the problem with just doing a single shot of HDR is that if we just hit you once, it doesn't matter how much radiation we used. We could use 5, 10, 20 times as much radiation. All your organs around it wouldn't like it if we did that. But that prostate itself is still probably going to have a little bit of cancer that was hibernating and it's going to live through that. So how we get around that is we combine that with some of the external radiation. The seeds get around that because that radiation is given over a long period of time. The other way that we might get around it is using more than one of these high-dose brachytherapy implants. So there's a bit of research now that's being done in using 2 of these fractions. So the high-dose rate implant, doing it twice but a week apart. And the thought is that anything that we don't get during that first treatment, well, we're going to mop up in the second treatment. So that's kind of up and coming and coming down the pipes. So in summary, high-dose rate brachytherapy in appropriately selected patients is a really good treatment option, and I strongly encourage patients to have a discussion about whether it might be right for them. But it's important to have that discussion with the physician and the medical team, because it isn't necessarily the treatment of choice for absolutely everyone coming in the door. We're learning a little bit more about using it on its own, so without the external radiation, and teamwork makes the dream work. So slide acknowledgement. So I did borrow some of the photos. A lot of these slides have data from various clinical trials. So most of those I've pulled from the actual papers, but there's lots of good Canadian research going on, and so lots of Canadian oncologists to thank for their help. I just thought I'd throw in one photo of my 5-month-old just for posterity, and yeah, she was not. We had fun. I don't think she appreciated the costume though. And as I understand, we've got the question period after, but this is your reminder, just think about some questions. So thank you so much for your time and attention. I really appreciate it.
Nelson, thank you very much. As we get ready for the break, I want to let you know about homework that I have for you during the break. We'll take a 25-minute nutrition, stretch, community building break. But I have a couple of pieces of homework for you. First of all, and probably most importantly, if you have questions from hearing about genetics from Justin, from high-dose rate brachytherapy radiation from Nelson, you have cards at your table. You have, you've got yellow sticky notes. You've got notepads. Please jot down your questions. And then during the break, and Anne-Marie, would you stand up for a second so they know where the table is? At this table at the front, there's a black basket. Bring your questions up, drop them in the basket, and I'll curate those questions for our panel members. Also, while the panel is up here after the break, if questions come up, we'll invite you to still put your questions down on a piece of paper, hold them up. Anne-Marie's going to circulate through the audience and collect your questions. So first of all, let us know what your questions are. The second piece of homework that I have for you is visit our presenters. We're really grateful for their support. We're grateful for them coming out because they also want to support men who may be having difficulties after prostate cancer treatment. And I want to address something that we have talked about at this symposium several times, but is still a little bit of a difficult topic to talk about. And that is that our presenters, two of our presenters today, are here to offer men options to manage erectile dysfunction. Ooh, I don't really want to go over and talk to them about erectile dysfunction. Let me show you this. You just did this. Yeah. You just did that in a room full of strangers. You can definitely go over and talk to our presenters. And then you might say, and this always reminds me, some of you will remember Guy Lafleur. I think our audience will know Guy Lafleur, famous Canadian hockey player. When Viagra came out in the late 1990s, Guy Lafleur was the pitchman for Viagra. Guy Lafleur, however, made it very clear that he was French, sorry, that's all I know, I don't speak French. I don't use Viagra. He made it very clear that he didn't use it, but he was obviously erection curious. And you might say, Kishore, erection curious is not a thing. It's a thing now, I just made it a thing. So definitely you can go over and speak to Bear from Osmond Erectaid Systems, and you can talk to Brenda from Medical Arts Pharmacy. So go over and talk to them. They're going to talk to you about some options, even if you're just erection curious. So we are going to take a 25-minute nutrition break, and my watch says 10:20. Sorry, yeah, 10:20. So we will see you at 11:15. Have I done the math right? I did the math right. We'll see you at 11:15. Have a great break. We are coming back from the break. And just to hear all the conversations that are going on is really tremendous. And I hate to stop them. But we will move on with the next part of the morning, which is going to be the panel discussion. And just while the panel, I'll invite the panelists up to the stage. And we've got these easy chairs for them. You know, from the start of the symposium, when we began it, we really struck a chord with the audience by providing an open forum segment with the panelists. And so this is your opportunity to have some questions answered. As I mentioned, each of the tables has some blank pieces of paper. If questions come up during the panel discussion, Anne-Marie is going to be keeping an eye on things, and if you have a question, jot it down, hold it up in the air, and Anne-Marie will collect it and we'll add it to the list. I am grateful for the list of questions that's come up. There's some really great questions that are going to address some really important points. And so just before I introduce everybody, I want to announce the prize winners of the draws that we had. So first of all, Brenda from Medical Arts Pharmacy has some little gift cards for you. And so after we're finished this morning, if you could go over and see Brenda, the following 5 people will get a gift card. Don Hull, was it Don or Dan? Don. It's Don Hull, gift card for you. Tom Mensink, gift card for Tom Mensink. You can see Brenda afterwards. Jim Batinsky, did I get that right? Jim? Not here? Oh, sorry. Right by the spotlight. Great. Gift card for you. Steph Schmidt. Yes, Steph, gift card for you. Kia Fry. Gift card for you. So those 5 people, please go and see Brenda at the end. And then Shannon from First Step has brought a certificate for the program. And Ernie Pilstrom. Ernie, I know you're here. There he is. There's Ernie. So Ernie, go and see Shannon at the First Step desk to pick up that. And thank you again to our presenters for coming and for being so generous to provide those gifts. And Shannon's also got these, just so you're not worried when one comes your way, which it's going to do in a second. These are very soft. These are not like billiard balls. Nice. Okay, we did leave a damage deposit. We're not getting it all back. All right, so it is time to convene our panel. You've already met 2 of our panelists, Justin Lorenz, and you've already met this morning speaking to us about genetics, and you've met Dr. Nelson Leong speaking to us about high dose rate brachytherapy. I introduced Mark Henbid, Dr. Mark Henbid, as a member of the organizing committee, but let me remind you that Dr. Henbid has training as a family physician, and his specific interest is in men's health. So as an associate with Saskatoon Urology Associates and in his own practice, his focus is men's health and talking to men about all sorts of issues, men and women, talking about prostate cancer, bladder health. And so I'm really pleased, Mark, that you've joined us this morning, because he's going to bring a little different perspective and expanding our perspective, maybe not only on prostate cancer treatment, but also issues of how does genetic testing influence how you might have a discussion with your family. So I thank you for that. Now we have 2 microphones, so there'll have to be some sharing that goes on. And I want to start off with this one because this one really intrigued me. Justin, this is going to be for you. So maybe people have heard of 23andMe. Maybe you'll talk some more about this. It sounds like this isn't the first time you've had this question. Will 23andMe give me any genetic information that can help assess risk for prostate cancer? Tell us about 23andMe.
Can you hear me okay? Yeah, okay, well. All right, so 23andMe is we call these direct-to-consumer genetic testing companies, and I kind of brand it as like a hobby test. You know, you want to know your ancestry, great for that. It gives you insight into whether you might have an aversion to cilantro. How, you know, if you can smell asparagus in your pee, like just like really interesting things that you kind of already maybe knew about yourself. If your hair follicles are thin or thick, you know, what your eye color's like, your general, like your ideal time of waking up in the morning. So these are interesting hobby things that 23andMe can give you insight into, but 23andMe also does give insight into medical information. They look at the genes BRCA1 and BRCA2. But when we do clinical testing, we read through a gene like you read through a book, line by line, page by page, looking for spelling mistakes. We find lots of spelling mistakes. These are variants. Most of these are benign. When 23andMe looks at BRCA1 and BRCA2, if you think of each of these being like 400-page books, 23andMe flips to one page of that book in the gene BRCA2, and it flips to 2 pages of that book in the gene BRCA1. So it looks at 3 pages of these huge novels. And so it's giving you a very small piece of insight. Now, those 3 pages are common sites where we find genetic mutations in BRCA1 and BRCA2, but only in people of Ashkenazi Jewish ancestry. So one of the challenges with 23andMe is that people will say, oh yeah, I had my BRCA1 and BRCA2 genes analyzed. You did not. They look to see if you had 3 common mutations that are only relevant to people of Jewish ancestry. And so people can be falsely reassured by that information. Now, recently 23andMe expanded that to look at 11 other pages, which are common sites where there are mutations, but 23andMe testing is by no means comprehensive. And whenever anybody does something through 23andMe, if they do find something that's problematic, it needs to be repeated in the provincial healthcare system and retested.
Okay, thank you. Can you hang on to the microphone for a moment, because there's another question for you, but it's also going to illuminate something that I want Mark to think about for us and address for us. And here's the question, or here's the story. It's quite a family story. My dad died of prostate cancer. All 3 of us sons got prostate cancer, 2 at age 55, 1 at age 73. My sister had breast cancer, 1 of 5 sisters. 1 sister had colon cancer. I have 2 daughters. What should they look at for, or what should they look for relating to genetically, and which gene?
Yeah, so that's a great question. So when approaching a family history with this much cancer in it, it makes me think right away that there is probably something genetic going on. The next challenge is it one of the genes that we know of today? And so oftentimes now when we do genetic testing in Saskatchewan, there's a panel of 16 genes that are analyzed. And these are of those 16, there's only 12 that I really care about. The rest are extra. And so going to get genetic testing for a cancer-related indication, you'll get covered for all of the important genes that we know of now. Family history of prostate cancer in and of itself, usually, and if it's not metastatic prostate cancer in the family, if it's intermediate risk prostate cancer, low chance that there's one of the known genes that's causing that family history. But when you start adding colon and breast cancer, it starts getting me thinking about the genes that we discussed. The Lynch syndrome genes, MLH1, MSH2, MSH6, PMS2, and then the genes BRCA1, BRCA2. As well as the genes ATM and CHEK2. And so as long as those are being analyzed, that's fair. And anybody who has had cancer would be eligible to get assessed and would be eligible for genetic testing in Saskatchewan with that family history.
So I won't ask you to tell us how it would happen in Saskatchewan, but in your practice in Toronto, or generally in Toronto, how would that testing happen?
Yeah, and so it would be the same in Toronto as here. Ooh, this is different. It'll be the same process wherein typically a family doctor would make that referral to, in Toronto, I would say your local genetics clinic. And so I feel like there's two clinics that are offering genetic testing in Saskatchewan. And the family doctor would know where that is. And the family doctor makes a referral and says, my patient has prostate cancer. He has this family history. I would like him assessed for genetics. That referral gets sent off to the center. A genetic counselor gets that referral, says, yep, this person looks like they're going to meet criteria based on their personal and family history, and then would order, bring that person in, talk with them, order the testing.
Okay, thank you. So speaking of family physicians, so Mark, that's quite a family story, and it strikes me that that is really illustrating one of the real benefits of a family physician who is looking at the entire family. So how would that look in a family practice? Is it routine to ask about family members?
Oh, absolutely. I mean, a big part of preventative health care is knowing a family history, and family history of cancers is a very important part of that. And so, I mean, in that family, you have risks of so many different cancers, and there's screening that should be done for all of those. You should be getting cervical screening, you should be getting prostate screening, you should be getting colon cancer screening, and there's different ways of doing all that. And with more details, there would be different recommendations on exactly how that screening should be done, whether it's, getting a colonoscopy for the colon cancer screening, or is a FIT test enough? And so with those extra details, then you get a personalized screening plan, essentially. And so that's, I guess, the importance of having someone who can ask those questions and know that about you and your family. It's the importance of that longitudinal care. Because, going to a walk-in and seeing somebody once, you can't get those answers.
So I have never, ever referred a patient for genetic testing. How often would it come up in a family practice?
I mean, my family practice is quite small, so it's not something I've actually personally had to do either, but it is something that I've definitely seen people who've had it done in the past, and they've had BRCA mutations, things like that, and then of course that leads to that cascade testing where now all their family members are getting tested and more people are finding this out, and that then leads to more and more people who are needing to go on these more advanced screening programs, essentially. And from what I understand, most of the referrals there would be going to RUH, into the medical genetics program there, here in Saskatchewan.
Thank you. A question about radiation treatment. I had external beam radiation treatment about 10 years ago. My PSA has risen to the point where I need hormone therapy to bring down the PSA or to control the cancer. Could high dose rate brachytherapy be an option for me?
It's going to be a bit of a qualified answer. So I think that's something that's a very valid question to ask, your current oncologist, whoever asked it. There's a little bit of research that's going into using high dose rate brachytherapy in very, very certain select patients who have had their prostate cancers come back locally after other treatments like radiation or external radiation or cryotherapy or even seed therapy. That said, it's for a very select group of patients because we have to be able to demonstrate that cancer is located in the prostate. Again, if the prostate cancer is elsewhere, it doesn't really help to provide the radiation there. And it's a very nuanced discussion with the provider because certainly giving the prostate a second look at the radiation, all of those tissues remember all the radiation we gave them the first time around. So doing it the first time, we were talking there was a pretty low risk of side effects, usually very, very well tolerated. And most patients, if they do get side effects, they tend to be pretty reasonable and well managed. But when we do a second treatment with radiation, well, now our risk of side effects is a lot higher. And so, and it's not just that the actual risk of getting any side effect is higher, but the severity of those side effects can also be increased. So there's a lot more risk to doing it as well. So before embarking on a procedure like that, you'd want to really, really make sure that, first, we want to make darn sure that the cancer is where we think it is so that we can actually treat it, but also that, a patient that's considering doing that, it would be willing to put up with these risks of side effects and complications compared to the alternative, which would be doing things like hormone therapy on and off, which might be a little bit easier to tolerate. So, that's something that I know in Regina we were starting to talk about doing treatments like that or considering it or looking at participating in clinical trials where we were doing that. But, I would say currently something like salvage using high-dose rate brachytherapy, that would definitely be kind of a one-off or a very personalized, custom-cut solution. So it's not something that would be offered routinely.
Okay, thank you. Now, staying with the topic of radiation treatment, what are the differences between SBRT and EBRT? And I'll ask you to explain what each of those is. Is SBRT available to Saskatchewan residents either in Saskatchewan or by traveling outside of the province?
So SBRT, or stereotactic body radiation therapy, the other abbreviation for it is SABR, S-A-B-R. Americans are cute. They like to make things sound like they're surgical, so, knives. But stereotactic radiation therapy is a subset of external beam radiation therapy. So the stereotactic portion, so getting back to our Greek friends, stereotaxy just means that we're using two or more ways of localizing what we're doing. So stereotactic radiation therapy is the same external radiation, but we're using more technology like pictures using CT scans, sometimes MRIs, sometimes some markers that can be placed inside the prostate to target our radiation. And that allows us to shrink down the amount of radiation that's being given to other structures because we can be a little bit tighter. So normally with external radiation, we have to leave a safety margin because prostates can move. We're pretty good about setting people up and making sure that we're hitting what we think we're hitting, but we still leave a few millimeters of, kind of wiggle room just in case that prostate isn't where we thought it was at the start of the treatment. Stereotactic radiation, well, we're now getting down to, a millimeter or 2 millimeters of precision. And if you can think about a ruler, like 1 or 2 millimeters, it's like that much. So being able to hit a target that small consistently, that's a real feat of technology that's come up recently. So the stereotactic treatment, it's still external radiation, but it allows us to do it faster. So we're able to, instead of doing 20 treatments with radiation or 28, we're now able to do it in 5 treatments. And just because we're less worried about hitting all those structures on the outside. So the good news is that there's a lot of research data about the stereotactic radiation, and at least in Regina, we had a program that was starting up, and at first it was just part of a clinical trial, but the clinical trial closed. Things were actually looking pretty promising, so I know the group was starting to do that as part of their clinical practice too. But that's definitely, just like the brachytherapy, it's a discussion that you need to have with your individual oncologist because sometimes there are technical factors that may make it less of a good idea. SBRT is also something you would typically, right now, most of our data is for kind of favorable or favorable intermediate risk patients. So the same group of people who would be kind of LDR candidates. So as we get into the higher risk patients, we're less keen to use the stereotactic treatment because, again, it's very precise, it's very confined, but just like brachytherapy, sometimes that benefit is also a liability. So more research needs to be done for those higher risk patients.
Okay, thank you. Justin, a question about genetic testing for relatives. If you've had prostate cancer, as has your brother had prostate cancer, and your sisters have had breast cancer, do your children or grandchildren qualify for genetic testing?
Yeah, it's a really good question. And so in my presentation, I alluded to this 50% chance that the gene gets passed on and how it's going to pop up in the question and answer, and this is where it pops up. If somebody has a genetic mutation themselves, that's ultimately who we want to identify the person most likely to have the genetic mutation. The person who's most likely to have the genetic mutation is the person who has had cancer. And if we can find that one family member does have a gene mutation that we think causes their cancer, that's half the work. Now we say, okay, we know what's causing this. Let's then test unaffected people to see if they've inherited it. And there's a 50% chance they did, 50% chance they didn't. So typically, no, kids is not where we start. They're unaffected people. I want to test the people who are affected to see if I can figure out what we're even looking for. And if I test everybody in the family and they're all affected with cancer and they all have a negative genetic test result, then I say, listen, if you don't have a gene mutation, there's no way your kids do, because they're inheriting their genes from you. So we always start with the affected people. And knowing this can save time, because if people are making if they're asking, for their children to get referred and those referrals happen, the referrals will get declined. And the genetic counselor will say, we need to test the person who's most likely to have the gene mutation, the person with cancer. And so even then, it's the person with the most aggressive cancer, the person with the earliest onset of cancer. That person in the family is the most likely person to have the gene mutation, because there can be this other thing called a phenocopy, which is really jargony. What that means is that maybe another sibling had cancer, but it just happened because of the sporadic reason, the random chance. And maybe there is a gene mutation, but we tested the person who was diagnosed at 70 with breast cancer, and that maybe just happened by random chance. Whereas her sister, who was diagnosed at 40, maybe that's because it was a gene mutation. And maybe the sister at 70 didn't inherit the gene mutation, but just got breast cancer because 11 to 12% of women will get breast cancer in their lives. And so.
Okay, so there's another question that I think relates a little bit to, or puts a different spin on that idea. And someone is asking, what is the cost of genetic testing if you do not go through a doctor or a specialist? So this makes me think then, is there private testing you could have done, and do you see any kind of problem with just going out to do private testing rather than selective testing with what you just explained?
Yeah, and so typically when there's a couple of reasons why people would pursue private testing. There might be some kind of a barrier. Getting into the city to do the genetic test is a barrier. The wait time is a barrier. And this person might be eligible to get genetic testing done. They might then say, well, listen, for 300 Canadian dollars, I can get this genetic test and I can get the results back in 2 months. That might be I might pay for that. Sometimes there are individuals who do not meet eligibility criteria, and they would never be offered genetic testing through their provincial healthcare system because their risk for having a mutation is so low. And that person may say, listen, I know my risk is incredibly low, I don't meet criteria, but I want to find out anyways, and I want to do genetic testing through a private option. So I come from a biased experience because I work at MedCam, which is a private healthcare facility, and I think when we get down to the nitty-gritty of things, I think that everybody should be able to get genetic testing. And so my opinion's a little bit skewed, but I strongly feel that if someone ever does pursue genetic testing, they should always be pairing that genetic test with meeting with a genetic counselor. And any center that provides genetic testing, if they do not also provide genetic counseling, don't do it. There's really good, some of the cheapest and most, and really, really good genetic testing comes from companies like Color and Invitae, and they do offer genetic counseling. Sometimes it's optional, and regardless of your genetic test result, always tick the option to meet with a genetic counselor, because there's always going to be very valuable information that comes from that. The challenge is that people might misinterpret their results, and a genetic counselor can avoid that circumstance.
Genetic counselor first before you get the testing done, or genetic counselor afterward?
Ideally both, but if you had to pick one, after.
Okay. Thank you. Here's a question that is not about radiation, but I want to use it to bring up a point. So what is high-frequency ultrasound that is used at Toronto University? So I will ask you to address that, but I think what this questioner is asking about is what's called focal treatment. So I want to expand the question to that. So we heard from Dr. Leong about treating the whole prostate, so total gland treatment. But there's a lot of thought over the last, well, even the last 5 or 10 years about, well, can you just treat a spot in the prostate and leave the rest of the prostate alone? So ultrasound, laser, heat treatment, freezing treatment, cryotherapy can be used for that. So if you want to talk about what ultrasound is, great, but can you also say, can this treatment you told us about, which is putting needles in, you put a ton of needles in, can you just put a couple of needles in and do focal treatment?
So that's a great question. So focal therapy versus treating the whole prostate, that's been a hot button topic for actually a couple decades now. And it's a really appealing idea. So one of the questions I often get asked at consultations are like, what are you treating? Are you just going to treat the tumor? I'm like, no, I treat the whole thing. And they're like, but only one of the cores was positive. I'm like, I still treat the whole thing. And the challenge is that when we do our biopsies, they're random samples, and it feels like those needles are really they're in there because they're really smart. But in reality, the core that they're taking out is very, very small in relationship to the rest of the prostate. So the actual sampling that you've done is actually a very, very small percentage of the whole prostate. Our technology's gotten better though, so now we have PET scans, we've got MRIs. So those give us additional information about where individual tumors might be located. But we still have two big challenges that we haven't quite completely worked around. Is one, are we completely confident that what we're seeing on these images are the only prostate cancer? So can we be confident that we haven't missed anything? And the other part is that, well, we know the whole prostate gland, it shares the same, for the most part, shares the same genetics as the rest of the gland. So, it came from the same person, so all the genetics should be the same. The environment should be the same because it's kind of being exposed to the same chemicals and everything else. So if you popped up a prostate cancer in one corner, what's to say that there isn't a prostate cancer that's going to pop up in the other corner and just hasn't gotten around to doing it yet? So those are the two biggest challenges in focal therapy. But focal therapy is very, very attractive because, in theory, if you can just keep the prostate cancer treatment down to one small area, maybe that will cut down on the side effects and the toxicity, especially if you're able to keep the treatment away from important parts of the body like the bowels or the nerves that are responsible for sexual function. So that's usually one of the big drivers because erections are important. So there's a lot of work that's being done in terms of high-dose rate brachytherapy, but also with cryotherapy and high-frequency focused ultrasound. So the interesting thing is that they all kind of work on the same idea. You stick some catheters or some needles directly into the prostate gland, and what's just different is that what you're using to actually treat the tumor is just a different thing to kill the cancer. So if we watch a cryotherapy procedure, it actually looks almost exactly the same as a high-dose rate brachytherapy procedure, but what's just different is they hook it up to a different machine and you're freezing the prostate instead of radiating it. That said, the focal therapies, we still need a lot more research to, I think, say that is, it's as good as another treatment option. So I think your mainstays of treatment are still going to be surgery, the radiation therapy, either external beam or brachytherapy. And outside of the context of a clinical trial, I find it very challenging to tell patients that this is a good idea. So it has a lot of attractive features to it, but I just don't think that the research is there yet to say that it's a safe and effective method of getting rid of your prostate cancer. We do see a lot of patients who have said, okay, I'm comfortable with that. I'm still going to get the high-frequency ultrasound or the cryotherapy. And the other challenge is if that prostate cancer does come back there or somewhere else in the prostate gland, we're now in uncharted territory. So it's also a lot harder to give patients good advice about, radiation and is this going to have more side effects or fewer or the same? I think those are all answerable questions, but we just need the data and the time to look for those answers and back up what we're trying to sell to patients.
Okay, thank you. There's always questions about.
I have an add-on question for that, if I could.
Yeah, please.
In saying that, one aspect that you looked at when in your talk was PSA and PSA progression, and the time it took for PSA to start elevating. I guess if you're only doing a focal treatment, PSA levels will always kind of be there as well.
Yeah, and so that makes follow-up a little bit harder, right? So, one of the things about prostate, people also ask me at consultations, well, how do you know that your treatment worked? And I wish we had a cancer detector. If I had one of those, I actually probably wouldn't be giving this talk. I'd be living in the Bahamas somewhere. Well, there isn't a nice scanner we can just stick people in and say, yes, you've got cancer, or no, you don't. And something like that would be really great. So the only thing that we have really, our best test is still actually the PSA. That PSA going up is going to be one of our first flags that something hasn't been taken care of. And that's going to flag even before a PET scan or a CT scan or an MRI, because all of those scanners, they require a certain amount of tissue to be in one place. So you need enough cancer to be able to see it. But the other thing is that some of those tests don't differentiate between prostate cancer that's dead or prostate cancer that's alive and hasn't been killed yet. They still sometimes look very, very similar on the scans. So the nice thing is after you've gotten your prostate taken out, your PSA should be 0. There should not be anything else making PSA in your body. Likewise, after radiation therapy, sometimes a little bit of prostate tissue lives through it. So, sometimes the PSA isn't quite 0, but it's pretty darn low. But in the case where we only treated part of a prostate, well, now you've still got 2/3 of your prostate that's still pumping out PSA. So that might make it a bit more challenging to be able to follow a patient and say, oh, your prostate cancer's back. But the other thing we know is that normal prostate tissue also kind of varies in terms of the amount of PSA it generates. So we might see a lot more bouncing around, and I think that's part of that research piece, right? I'm not saying it's not a good idea, but part of that research might be learning how to effectively manage those patients and trying to answer those questions is like, how do we know if the cancer's been taken care of?
Thank you. So you upgraded from Regina to Calgary. Now you want to upgrade to the Bahamas?
I mean, like, I'm a prairie boy, right? So I'm not afraid of cold weather, but at the same time, eczema is a terrible thing, right? So, like, can you blame me?
So there's always questions at a meeting like this, and quite rightly, about PSA testing. So we've heard a little bit about this blood test, which helps us understand how successful a treatment has been. But the other side of PSA, or prostate-specific antigen testing, is in detecting cancer. So the vast majority of men who are here today who've had a prostate cancer treated, it was found because they had this blood test done. And so I know that this audience, at least I think this audience, will be pretty keen to say, well, let's get PSA testing done. But as we've talked about at almost every symposium, it's not that clear. So this is going to go to Mark, but I know that, Justin, you talked about if it looks like there's a higher risk in a family, there should be screening done. So that's one perspective, which is from a genetic counselor looking at people at high risk. But the other perspective is from a primary care family physician aspect. So what is the current thinking on offering men PSA testing?
Yeah, it's a great question, and it's actually something that's quite controversial still in primary care, because PSA testing, it's great in certain circumstances. It's great for tracking treatment, things like that, but as a screening tool, if you were to simply test every single man in the world at age 50, you're going to find probably 2/3 of them are going to end up with a positive test that was not relevant. That cancer would never have caused them problems. And so that's overdiagnosis. And so with a test like the PSA, it can't tell necessarily how severe that cancer is until you start getting tissue, until you start doing more advanced screening. And so that's why technically the current family medicine recommendations are not to offer PSA screening to everybody. You offer it in select circumstances to select patients after a discussion of the risks and benefits, because there is a decent portion of the population that would actually be harmed by PSA screening. And so that's why you have to ask those questions of family history and other risk factors to find out, is it worth the risk of doing this screening? Because the consequences of prostate cancer treatments can be quite devastating. You know, things like erectile dysfunction, incontinence, those are, you know, for most of the treatments, not potential risks, they're almost guarantees in a lot of cases. And so you don't want to put people through treatments they don't need. But of course, it's also too simple to simply say, well, we don't screen anybody, because clearly then you're going to miss a lot of cancers that are going to kill people and cause a lot of problems. And so that's where, you know, things like the genetics come in, and trying to find who would benefit from this screening versus who shouldn't be screened because it's only going to cause harm. And so, like I said, the current family medicine recommendations are to, you know, be quite selective with that screening, but they don't actually give a lot of recommendations on, you know, exactly who should get that screening. Whereas more recent Urological Association guidelines, you know, are recommending that if you have those risk factors, you know, that first degree relative, well, then maybe you should be starting your screening even a little bit earlier, say 45 rather than 50. But it's, you know, a lot of, it has to actually be a proper discussion. It shouldn't just be a reflex that you're 45 or you're 50 now, so you need this testing done. It should be something that you have a very informed conversation with your doctor about based on your personal health history and your family's personal health history.
Thank you. A very difficult topic, and thanks for your thoughtful review of it. Before I ask Justin if he wants to comment from his perspective, I want to say I would imagine in this room that was maybe a little difficult thing to hear, that maybe we shouldn't be doing testing on everyone, because everybody or the people who'd be motivated to come out today are here because they had their cancer found through PSA testing. Justin, I wonder if your perspective is different as a genetic counselor, or how is that, how would you, because the man who's got the diagnosis, the PSA is already done, but how would you give counseling to their son about PSA testing?
Yeah, that's so I mean, there's those kind of three risk groups that we talked about: individuals with family history, individuals of West African Caribbean ancestry, and individuals with gene mutations. And if someone comes to me who's unaffected, who has one of these gene mutations, we start PSA screening at age 40. And we do that annually. And I typically counsel people that in their 40s, we're not necessarily even screening for cancer. We're just establishing that person's baseline. So that, you know, there's this campaign that happened once: know your number and know what your average PSA value is. For individuals with family history of West African Caribbean ancestry, there's this kind of unspoken rule of you start screening for things 10 years prior to the earliest diagnosis. It's not really put in there's not a lot of evidence for it, but it's kind of just something that people tend to do. And so sometimes that lands people at starting screening at age 40. Starting prostate screening at age 40 is pretty controversial, but in our clinic, we do that at Sunnybrook for people with who meet one of these three risk factors. Yeah, I mean, I worry about the next generation. I also worry about siblings and making sure that brothers are being screened regularly. But a lot of that goes then to the family doctor. And some family doctors, the opinions vary between family doctor to family doctor. And some patients will say, hey, my family doctor's never offered it to me. And some people say their family doctor's been screening them for years. And so there's still lots of, the guidelines haven't been updated in so long. I think new ones are in the works. I know new ones are in the works.
I believe the current family medicine prostate cancer guidelines are from 2014, if I remember correctly.
Yeah. And so you mentioned the urological, so there's the Canadian and the American Urological Associations who have updated guidelines, and they're vastly different. But even the American Preventive Task Force, their guidelines have been updated, but are still a little more kind of conservative. Anyway, so to answer your question, that's how we kind of approach. But when it comes to these gene mutations, Sometimes there are risks for other things like male breast cancer, colorectal cancer. And so we then tackle those other sites because of the genetic risk, even if there's no family history because of the genetic factor.
It strikes me that prostate cancer, or a prostate cancer diagnosis, or maybe any cancer diagnosis, obviously is a very personal thing. Some people, today's attendees as an example, are open to the idea of other people knowing about a diagnosis, but I've certainly met people who do not want anyone in their family to know for a variety of different reasons. So then we could have a situation where a man was diagnosed with prostate cancer and he says, don't tell anyone else, not for a bad reason, but just wants that privacy. Yet, this morning we've heard very strongly that in fact you may be withholding really important information from your family. So from a family medicine point of view, you may be seeing multiple members of this family. What is your responsibility, or how would you go about that if the son came in and his father has prostate cancer?
That's a difficult thing to deal with because, of course, a patient has every right to privacy in those situations. But, I mean, if I know that there is that family history, I'm probably going to encourage them a little more strongly that they should be having screening, even if I can't directly tell them why. Because, you know, I can't break that confidentiality that their father has, or uncle, or whoever. But I can, you know, encourage them that this is something that would be a very reasonable screening to do. And try to recommend them through that without providing too many details. But it would definitely be a lot easier if people were willing to have a more frank conversation with their family about those kinds of risk factors, because it affects everyone in the family, you know, men and women included, as we've seen from different hereditary factors. It's not just about prostate cancer. There's other cancers that have relations as well. So it's important to, you know, share that things, and it's nothing to be ashamed of. It's not something that you did to get cancer. And so it's just best to have an open conversation and do whatever you can to move forward.
Justin, am I fussing over nothing there, or is that something that practically comes up?
Yeah, I think it's a really brilliant point. I appreciate. I've never had a detailed kind of thought process about that in a setting where I was meant to think critically about that scenario. And one way that you can frame your family history is like a mini genetic test. Some people will get a positive genetic test result and not disclose to their family members, and they also have that right. And it's very challenging as us, because we, as another part of our job, is to help encourage people to share this genetic information, but they may say, I would feel so guilty if I passed this on to the next generation, or I couldn't, I would hate it if my children resented me for this. And we have these open conversations about, well, do you resent your parents? They pass that on to you. And they say, oh, absolutely not. And it's like, well, great. You can assume that your kids won't resent you either. You gave them a whole bunch of great other genes. Like, this is fine. I also tell people that we all have about 5 gene mutations that we're passing on that are causing health issues. And so we just found one of them. The disclosure, so, changes in screening. If you have a family history of colon cancer, then you get, you might be a better candidate for, you might be offered colonoscopy as opposed to the FIT test. If you have a family history of skin cancer, then you're going to get dermatological examinations. Your care changes based on your known family history, and no one's looking for pathology reports. You just declare what your family history is, and then you suddenly get access to a whole bunch of services if you have a relevant family history. But I see lots of people who have 2 circumstances. One, cancer is taboo, it's not talked about, so they just don't know. And then the other one is that people just died in the village, and we have no idea why. And it's like, those are gaps in your family history that are preventing you from accessing potentially services. And so, yeah, it's a really good point.
Thank you. There's a couple of questions on a similar topic, and a dreaded topic, and that is cancer returning. So Nelson, let me put the first question to you. If you're a survivor of prostate cancer, is PSA testing, so person's had treatment, is PSA testing all you need to focus on other than healthy living? So would a person need any other testing other than a PSA test if they've had radiation treatment?
So we kind of come at it from a few different angles. So when you're on that observation, there's an actual medical term that we use for it. It's called survivorship. And it's probably actually one of the most challenging phases of your prostate cancer journey because it's a difficult place to be sometimes to not be on treatment anymore. So I have a lot of patients that tell me, you know, when you're on treatment, you have something else that you're supposed to be doing in X number of days, right? But once you're all done your treatment, it's like, okay, now what? Right? Because you've got time to actually think about things and process. So we have to kind of take survivorship from a whole bunch of different angles. And the one that we tend to focus on the most is the cancer coming back, yes or no? And usually the most common test that we use for that is PSA. And currently most guidelines don't recommend the use of other imaging tests like bone scans, PET scans, MRIs, for some of the reasons we talked about before, right? So most of those, we still don't have the cancer detector, and most of those other scans aren't going to be as sensitive as the PSA, and they're also not going to be as specific in saying, hey, this actually is a cancer that's active. So for the most part, if we're just monitoring for whether the cancer's come back or not, we usually, just stick with the PSA at regular intervals. And I usually tell my patients, I would still recommend doing the PSA lifelong, as long as you would be willing to take some sort of treatment, any treatment, whether that's hormone therapy or something that we've invented in the future. As long as you'd be willing and fit enough to take a treatment, I think it's worth knowing if that cancer's come back. If you're 120 and you said, hey, even if I got the cancer and it came back, I wouldn't do anything about it, then maybe we don't look because you're not going to do anything with that information. So that's kind of the first piece, of the survivorship. But the other two, big components or three components. One of them is the healthy living, and so you do want to make sure that you're still seeing your family doctor and taking care of the rest of your health, because the prostate cancer, unfortunately, does not give you a free pass for every other kind of cancer. And it also, doesn't help your heart health or anything else. And so there's still a lot of other preventive maintenance and healthy living. We also need to make sure that from a, mental health standpoint that you're well supported, because it is sometimes a very challenging phase of your journey to just kind of be out there and have time to ruminate and stew. So, still, again, lots of reasons to be in close contact with your primary care provider. And then the other thing that we do recommend for follow-up is monitoring for side effects or toxicity. So less so with surgery, but especially with radiation, it's sometimes the gift that keeps on giving. So even though the radiation is not active, it does its work, passes on through, the damage that's been done from the radiation therapy may not make itself apparent for years or sometimes even decades after the therapy. So having follow-up with your family physician to mention new symptoms or problems could be really, really helpful in terms of managing your overall health care. Also, sometimes, new symptoms or problems may be that first indication that there's something, not quite right from a cancer standpoint. Although I tell patients, every pain that you feel is not going to be prostate cancer. Like, the PSA is pretty darn good at picking stuff up, so don't fixate on it. But having that constant contact, again, I'm leaning on Mark a ton here. But the most important thing, I think, is having a family physician to make sure that you get that longitudinal follow-up survivorship care.
Thank you. So two follow-up questions that relate to that. One is essentially saying, you said that the PSA test is important, and you use the word sensitive. That is, if the cancers come back, will it pick it up? But is it sensitive enough? And I think what this person is asking is, if my PSA is staying steady, can a cancer ever come back? So will a cancer come back and the PSA doesn't show it?
In theory, it's a very, very small percentage of prostate cancers can come back, and they can come back without increasing that PSA. So particularly aggressive prostate cancers will sometimes forget how to make PSA. But I highlight to people that is a very, very, very small percentage. Now, I know from a psychologic standpoint, we have a tendency to to highlight things that are very unlikely, and that's just the way our brains work, unfortunately. So, now that I've said that, people are still going to be like, well, you said the PSA wasn't always going to work, so maybe I should be doing. So seriously, the PSA, I would say, over 95% of the time is going to be your very first indication that something came back. The only other exceptions I can think of are, maybe, I think once in my practice. And I've been practicing for over 10 years, right? So once in my practice, it came back without increasing the PSA, and the first thing that we noticed was actual symptoms. The other thing is that sometimes the prostate cancer, if you've skipped a few PSAs, sometimes it can come back as symptoms before it gets flagged on the PSA because the PSA wasn't done often enough. But that's also why we recommend following up with a care provider who can tailor how often should we be doing these tests to make sure that we're not poking you so often that we're causing undue hardship and mental anguish, but also often enough that we don't miss something.
Okay. And the final part of the question for cancer coming back. So if a person has had radiation for prostate cancer and the cancer recurs, is surgery still an option for them?
And the urologist is asking me that. So the short answer is
I'm the MC.
It's a conditional, in theory, it's a possible treatment option. And I've actually had a few patients that have unfortunately had their prostates come back, prostate cancers come back locally. So again, we have to make sure that the problem is definitely local. And then those patients have actually gone on to be salvaged with surgery, and that's been done here in Saskatchewan. The challenge, though, is that just like doing a second course of radiation therapy might have more side effects, certainly doing surgery after radiation is going to have more side effects because there's going to be scar tissue, things aren't going to heal quite as well. So that risk-benefit ratio is certainly going to be a lot different. So it would be very wrong for us to just say conditional yes, everyone could get that as a treatment. It's only a very small select group of patients that would be fit enough, have that local recurrence, but also willing to accept the side effects or possible complications that could come from that to use that as a salvage option. Some of my younger patients, who unfortunately are in that situation, we explain everything to them and we tell them about the risks, the side effects, and a surprisingly large proportion of those patients after hearing that say, you know what, the hormone therapy doesn't sound great, but it actually sounds better than what you just described, so I will take the hormone therapy. So that's a very personalized, customized discussion, and a very nuanced discussion to have with your providers.
That's what I was going to say too. So thank you. All joking aside, I 100% agree with your thoughts on that. So the discussion about genetics has brought up a lot of questions, and people are obviously thinking about, is this right for me? So some of this is pretty Saskatchewan specific, so if you want to address what goes on in Toronto, that would be fine. Or I did hear you talking about some things you know about Saskatchewan. So how do I access genetic testing in Saskatchewan? Who do I speak to about genetic testing? And can any family member ask for genetic testing if one parent has cancer?
Okay, so that's good. My brain works in such a way that I'm not going to remember all three of those questions, but I'll start with the last one because that's also the way my brain works. So if someone's had a first-degree relative with cancer, it really depends upon a couple of factors whether or not they'd be eligible for testing themselves. And I'm assuming that the person who would be asking that is unaffected. So there's, I talked a little bit about that paper that showed there's a 12% chance that someone has a gene mutation if they have metastatic prostate cancer that's spread. For ovarian cancer, there's a 20% chance if a woman has ovarian cancer that she has a gene mutation. For pancreatic cancer, 16% chance if someone has pancreatic cancer, they have a gene mutation. Male breast cancer, over 20% chance that man has a gene mutation. And so these are the family history cues, where if you have a first-degree relative who has pancreatic, ovarian, or male breast cancer, then you may be eligible for genetic testing as an unaffected child or sibling. Those are official criteria in Ontario. Anybody who has that family history and is unaffected would definitely be eligible for genetic testing. I can't speak to Saskatchewan's criteria for everything. So there's that. If someone had, a family history of a father who had metastatic prostate cancer and that's it, I think it's unlikely they'd be eligible for testing in the Saskatchewan healthcare system. They would unlikely be eligible for testing in the Ontario healthcare system too. Because although it's a 10% chance, 50% chance it's passed on, so it's about a 5% chance for the individual, and that's too low. The other question, can you prompt me, please? Do you remember?
Yeah. I think we're going to move on to the next question.
That's fair.
Thank you for addressing that. Because, hang on to the microphone.
Okay.
And we're reaching the end of our panel session. I apologize if your specific question wasn't addressed. There were some questions that kind of fall outside the expertise of our panel. And so I haven't brought those questions up. There's a question specifically about Saskatchewan, and maybe I can address this. Are all high Gleason score cancer cells automatically submitted for gene testing? So that's the really malignant high-grade cancers. So when those are found on a biopsy in Saskatoon, yes, those samples are sent out for genetic testing. And one of the reasons that might be done is to determine, can that person have a specific treatment in the future? Did you mention PARP on any of your slides?
I alluded to it as the treatment
Did
for
you?
BRCA1, BRCA2, and ATM.
So there's a question of what is PARP?
Yeah.
So that ties quite a bit of this together. Tell us about that.
Yeah, so PARP, we call them PARP, and these are types of medications that take advantage of how cancer occurs in people with BRCA1, BRCA2, and ATM gene mutations. We call this, these three gene mutations. And the mechanism is that all of these genes have something in common. They all repair DNA. And the cell typically has two main ways of repairing DNA, using the BRCA genes and then using the PARP genes. Cells that are cancerous typically have issues in their DNA repair genes. That's why they accumulate so many mutations. And so if they have a mutation that someone's born with in the BRCA1 gene, likely that cancer tumor has some problem with that pathway of repairing DNA. And that cancer tumor is depending on the PARP pathway to repair its DNA, because if it can't repair DNA, even the cancer cells will die. So PARP inhibitors inhibit the second pathway of DNA repair. So what they're doing is they're basically saying, listen, all of your healthy cells are going to be able to use the BRCA pathway. Your cancer cells probably have this pathway knocked out. So what they give people is PARP, so that the PARP pathway is knocked out, and only in their cancer cells is the BRCA pathway knocked out, so these cancer cells no longer have a way to repair DNA and they die. And so what oncologists will do now is they'll say, listen, I want to see if that cancerous tumor has mutations in the BRCA pathway, because if it does, then I can give that person medication to knock out the PARP pathway, and that can be a treatment. So they'll ask for the tissue to be analyzed for, and in Saskatchewan currently it's just BRCA1 and BRCA2. ATM is not looked at, but that will likely change. But these are the bigger ones that I'm most concerned about. And so that's the tissue testing. And then they may say, okay, let's see if that mutation's only present in the tissue, or let's see if that person actually inherited that gene mutation. And then they'll go on and meet with the genetic counselor and do the germline testing. So those are the kind of pathways. The other thing is that, we talked about Lynch syndrome connected to colon uterine. Well, the tissue testing does not look at Lynch syndrome. And someone could have a Lynch syndrome thing or mutation that's causing their prostate cancer, but they got their tissue testing that came back negative because it just looked at BRCA1 and BRCA2, and that person's still eligible to get germline testing to see if they have Lynch syndrome. And so we have to make sure that that's happening so that the oncologists don't stop at the tissue. They say tissue's negative, this person's good. No way. We still have a whole bunch of other genes we can look at, so they still should be referred off to genetic counselors. And so this is happening a lot in the oncology centers here. The tissue testing, it's not reflex. So sometimes, and eventually it'll happen probably in Saskatchewan in a few years, where any person with metastatic disease automatically just gets triggered to test the tissue to see if there's these gene mutations, and then a referral to genetics will be made afterwards. But everybody with metastatic prostate cancer, I was talking to Andrea Harwish. I said I wouldn't mention her name. She's one of the genetic counselors here in Saskatchewan who I work with, who does lots of work with prostate, who runs the mainstreaming program with prostate. And she should be seeing everybody with metastatic prostate cancer now for germline genetic testing in Saskatoon.
Thank you. So, new treatments, new diagnosis, opening up new hope for men. So, I want to thank you for all these questions. Thank you very much. And I want to thank our panelists, Justin, Mark, and Nelson, for coming out and helping us understand things better, and for your considered answers. Thank you very much. Thank you. Okay, so that concludes our presentations for this morning, but before I wrap up, I want the opportunity for us to hear from the organization who ensures that this annual symposium happens every year. I heard from Brent that one of the attendees here today, and he's standing up, is a very enthusiastic supporter of Motorcycle Ride for Dad. And it's Don Sapsford. So Don, thank you for being here today. And I heard something interesting about your fundraising. Tell me about that.
I started out just going asking people for money, and I didn't like that very much. So my daughter and wife got together and said, what can we do to get people to come to our place and just donate money to the Ride for Dad? So we started having a car show in our yard. We got sponsors to donate food and beer, and we gave the beer and the food away if they made a donation over $20. We got donations over $500, $1,000. Hardly any of it was $20. And each year we had the car show, we raised over $14,000 each year.
Over the whole time that you've been raising money through Motorcycle Ride for Dad, how much have you raised?
$109,000.
$109,000. So that seems like a lot. How does that stack up against other people across the country?
There's only 6 of us that have raised over $100,000.
Wow.
In Canada.
Congratulations, and thank you. So why do you do it?
Because I had prostate cancer, and it's a good cause. When I first got, I went for brachytherapy in 2011 in BC. We had the car show after that, and people care. People really do care, and we let people know that I had prostate cancer, and they kept coming. It was terrific. People really do care.
Thank you for your efforts and your inspiration. Thank you. I also want to mention, and I think this relates a little bit to your work, Sandia. Last year, we were really excited to have a presentation from one of my partners, Dr. Jana, about a surgical robot. If you were here last year, he told you about the robot we were getting at St. Paul's Hospital. We have it. It is used all day, every day. We're very excited about the program, and we're very excited about the support that we've had from St. Paul's Hospital Foundation, who partly funded that robot. It is in so much heavy use, we need a new robot. So we're looking for a second robot. I don't know if your pockets are deep enough for that, Sandia, but I know you want to talk about other fundraising, so thank you and welcome.
Thank you so much. It's really my pleasure to bring greetings from St. Paul's Hospital Foundation. Unfortunately, our CEO, Lucina Hickey, who many of you know, she has fallen ill today. So I'm speaking on her behalf. So our foundation is just honored to fund this symposium each year. And it's really through the generosity of our donors and our sponsors that this event can happen, particularly our presenting sponsor, Motorcycle Ride for Dad. Thank you so much for the $15,000. That was really tremendous. And also the Saskatoon Prostate Cancer Support Group. And also the Saskatoon Prostate Cancer Support Group, which many of you know of and take part in, and Saskatoon AV, who came on just recently. I'd like to thank my fellow members of the Volunteer Organizing Committee who selects the speakers and ensures a truly educational event. This is my first year on the committee, and it was really great. And the first time I'm attending the symposium, and I'm really enjoying it. I find it quite fascinating. And I'd really like to thank our committee co-chairs, Dr. Vishwanathan and Murray Hill, who I don't think needs any introduction, either of them. This symposium would really not happen and not be possible without them, so I want to give a special thank you to them. For the past 11 years, this committee, under the leadership of Kishore, has been creating a supportive and informative space for patients, families, and healthcare providers. I hope you've learned as much as I have. I want to thank our new event coordinator, Anne-Marie Say, and our videographer, Matt, for their helpful work. And I'm going to look forward to viewing this again online and taking some more notes. And of course, a special thank you to our wonderful participants, Justin Lorenz, Dr. Nelson Leong, and Dr. Mark Henbit. Very, very helpful today. The expertise brought by you is invaluable to us, and we look to you to help guide our understanding as patients and families work their way through this disease. And it is through your eyes that we can see the potential for innovation and the ways in which our foundation can best support our patients. As the fundraising body for St. Paul's Hospital and the hospice at Glengarda, our foundation supports state-of-the-art equipment, programming, education, and special initiatives that do so much for the health and well-being of the community. Urology is one of our most important hospital leadership areas, and we endeavor to bring fundraising projects to our hospital that have meaningful impact on patients facing issues like prostate cancer. Last year, at this very symposium, we had the opportunity to hear about the Apleo ultrasound technology and how beneficial it would be to those patients who require prostate biopsies. And I'm proud to say that in the last year, we have been able to not only secure the funding for the Apleo ultrasound, but the machine, like the robot, is in full operational use at St. Paul's Hospital, which is really fantastic. This Apleo ultrasound has meant that the risk of infection for those receiving prostate biopsies has gone from as high as 6%, with the potential for significant and even fatal complications, to almost 0%. It's just phenomenal. I just want to thank everybody for that. So now patients can receive local anesthetic outside of the operating room, and moving forward, the need for preventative antibiotics will be reduced. Patients will no longer need to go under general anesthesia. They'll have much less pain and blood loss and are able to go home quite a bit sooner. And we're really finding that with the robotics that's happening, that we're getting through patients faster and patients are able to go home sooner. And this Apleo ultrasound means that patients have been feeling well enough to leave the hospital within 15 minutes of completing the procedure, which is just phenomenal. The Apleo ultrasound was brought to St. Paul's Hospital through the generosity of donors. The Associated Radiologists brought this idea to our foundation and then came on as a donating group. They gave $80,000 towards the acquisition. And then Leo Barassa and Daphne Arneson, two individuals who are wonderful individuals, they gave a gracious gift of another $80,000, and we were pleased to honor and thank them at the National Philanthropy Day luncheon just this past Thursday. And so Due to those two donations, we've got this equipment in place, and we know that this new equipment, like this event that we have today, is improving the health and well-being of those facing urological issues. And this will really help our hospital achieve its mission of delivering compassionate and holistic care. So these kinds of innovations and aspects of care are a result of the vision of our dedicated healthcare providers and also the support of our community through our foundation. And as we gather for this symposium each year, it's our hope and our intention that you're able to learn more about the options available to you, and also that you can come here and find community and like-minded individuals and others who are going through this and be supported. We hope that you consider how you may continue to help the continued growth of urological care in our province. Events like this symposium, facilities like the Urology Center for Health, and equipment like the robot and Apleo ultrasound are all made possible through the generosity of our community, and we invite you to be part of that community. If you would like to support projects like this symposium, please take one of our How to Help brochures on the table, and you can direct your gift directly to this symposium or to the Urology Center if you wish. And just want to thank you for being part of this symposium, and I'm so pleased that each of you could be here today and advance your learning and build community. I hope you leave here today with hope and feeling the support of all of us behind you as we work to create a community of health, hope, and compassion for all. Thank you.
Thank you, Sandia. Those of you who have attended the event before know that we really rely on your evaluation to build next year's event. So this year, an online survey will be sent to you by email. Please take a moment to complete it, especially let us know what topics you'd like to hear about in the future. And we hope that we've provided you with some valuable insights and information today, and look forward to seeing you again in 2024. There are some certificates of attendance if you are a professional who needs that for your professional learning hours. They're at the table at the front where you came in. And I was so pleased to see many nursing colleagues here today, so thank you for coming out. And if you need a certificate of attendance, it'll be at the front desk. If you know of others who should attend, please share the word and save the date for our 12th annual event happening right here on Saturday, November 9th, 2024. As Sandia said, if you would like to support this work or other work helping men with prostate cancer or make a donation, please feel free to either contact the Foundation office at St. Paul's Hospital, or there are flyers on your desk with postpaid envelopes in which you can make a donation. Finally, if you were one of the lucky people who won the gift draw, please make sure you go over and pick up your gift before you leave. Take care, everyone. Thank you so much for spending your morning with us, and I wish you a great weekend. Thank you again.